morning, everyone. Good morning. Oh, great. Must work. Can you hear me? Now? Hi, good morning, everyone. Can you hear me in the back? I see nods. Wonderful. Okay, great. Well, welcome, everyone. And please take your seats. We have some seats in the middle and some seats on this side here. Okay, let's get started. So welcome to this symposium today that's entitled Global Health at the Crossroads. I'm Wafaa El-Sadr. I'm the Global Director for ICAP at Columbia University. I'm also Executive Vice President for Columbia Global. And it gives me great pleasure to welcome you to our symposium today, in which we will learn a whole lot about the HIV response, but in addition also we will learn about some of the other global challenges that the community is facing, that communities are facing around the world. Before we get started, I want to invite Dean Linda Fried, who's the Dean of the Mailman School of Public Health, who's going to give her own words of welcome. Welcome, Linda. Thank you.
Well, good morning. It's my privilege to join Wafaa in welcoming all of you today to what ICAP and certainly this great School of Public Health and everybody in this audience does so well, which is to really honor the accomplishments to the present and today celebrate them and set the stage for an ever better future. So thank you for being here. I'm so pleased to see everyone as we begin a day celebrating, as I said, the transformative work of ICAP over the last 20 years, which is really a product of everyone in the room under Wafaa's great leadership. And then we're going to think together about how we apply these learnings to the public health challenges of this ongoing and future century. I want to start by just thanking all of our panelists who are here with us today, who I know will lead us through very robust dialogue to meet these goals. Angeli Achrekar, Solange Baptiste, Mesvin Teklu-Tessima, Terry McGovern, Peter Ehrenkranz, Ambassador John and Keng Sagan, Rose Nyurenda, Jeff Shaman, and Ashwin Vasan. And thank you all together, and our panelists in particular, for your fierce support of Columbia Mailman's ICAP. Your work, ICAP's work across the globe is important, but everyone here I know as public health warriors. And thank you to the incredible leaders of ICAP. I'm looking at your faces all across the audience. And you are celebrated here today by all of us as true leaders in the field and people who know how to put together a great symposium. So thank you. As many of you know, and maybe all of you know, over the last 20 years, ICAP has reached millions of people, millions upon millions of people in low and middle income countries, and saved millions of lives, delivering everything needed from HIV testing and treatment to tuberculosis screening to support maternal health and child health, to responses to emerging infectious disease outbreaks, and so much more. You can look at some of the numbers over the past 2 decades. With the HIV epidemic at the leading edge and the forefront always of ICAP's work, ICAP, all of you, all of us together, have supported HIV testing for 51 million people, screened 9.2 million people living with HIV for TB, enabled 2.4 million people living with HIV to access treatment, and facilitated access by 218,000 individuals across 40 countries to PrEP. Through this work, ICAP has consistently created and brought innovations to imagining health systems for the future, to delivering the goods on how to support building them, to strengthening health systems, to training health workers, over 400,000 health workers around the globe. And of course, these things are all interrelated. Training these health workers has strengthened health systems, as has the creation of laboratories that can bring the state of the art to the accomplishment of health. I gave you some numbers, but I want to also add my own observations on the secret sauce of ICAP. And it is both great leadership at the top and shared leadership in every country and in every team with a shared vision. But the other secret sauce, which I felt so powerfully last night, is the element of bringing hope and creating hope. In a world right now with so many sometimes overwhelming challenges that are essential to solve, health for probably many of us is a decision we make every single morning as you get out of bed. But delivering hope so that everybody can believe it's possible is another level of leadership. And then adding to that, ICAP's very important model and ability to link hope to scale so that we can deliver hope for an individual and scale it to the millions of numbers I just told you, and the country about country that is positioned so well for leadership to continue to amplify hope. Marriage of hope and scale is a critical marriage. And now, as we enter the second century of public health, defining public health as the actions we must take collectively to create healthy people and healthy populations, we bring all of these innovative methods, capabilities, experience, and hope to our emerging public health challenges. From the health impacts of climate change, to always addressing health inequities, to enabling people now living longer lives, to live them with health and to care for them with humane capabilities, to managing emerging infectious diseases, preventing future pandemics, and so much more that we must bring together in the delivery of the critical foundation of health for all of us. Each day, I am always moved and impressed by ICAP, bringing the evidence of academia, the rigor of academia, the highest quality research to support innovative thinking, and really then infusing that into the building of true partnerships to advance public health in a framework of going from hope to scale. As you hear from our global health experts today, I encourage all of us to consider how we together can take the learnings from ICAP's 2 decades of experience addressing global health challenges to the challenges we face in public health, the public's health, going forward. Thank you and welcome.
Well, thank you very much, Dean Fried, and very much appreciate your words that I'm sure will guide us throughout the day today. I'm going to give you a little bit of a description of how the symposium will go. We have 2 sessions at the symposium, and the first one is going to focus on HIV and reaching HIV epidemic control and beyond. And then we will also as well move to the second session, which will be focused on other areas of global health and where are we going at what we need to focus on moving forward. The sessions have the following structures. We'll start each with a keynote address, and then they'll be followed by a panel discussion. Panelists will be invited to sit up front, and we have a lightning round at the beginning where each of the panelists will be sharing in brief some of their thoughts on the particular topic of their interest and in the context of the session itself. And then after this, then we'll have a moderated discussion, conversation between the moderators and the panelists. And then we'll open it up to questions at the end to all of you. So keep that in mind. So take down your questions and keep your questions till the end of each session when we invite the questions from the audience. Okay, so that's a very fast run through of the agenda for today. So let's get started with our first session today, which, as I mentioned, is entitled Reaching HIV Epidemic Control and Beyond. And I'd like to welcome Dr. Jessica Justman, who's going to be giving the keynote address on this for this session. And Jessica is the Senior Technical Director at ICAP at Columbia University. Welcome, Jessica.
Good morning. So today we have an audience that includes many with decades of experience on this topic, but we also have some who are new to this topic. And I hope that I will be able to share something of interest to all of you. And here's our overview. We'll just take a look at a few global snapshots to ground our conversation and review accomplishments of the HIV response. We will take a look at the gaps that exist in epidemic control and some threats, and then we'll spend more time on the ways to move forward. So to start first with global snapshots, usually this is presented with just the column on your right, where we are now in 2023. But I think it's really helpful, especially given the 20th anniversary of ICAP, to take a look at where we were 20 years ago. And we can see that between 20 years ago and now, we still have about the same number of people living with HIV. And that is something to work on. The number who are accessing ART is vastly improved. It's 75 times higher. The number who are newly infected with HIV got some improvement. It's about 4 times lower. And the number of AIDS-related deaths is about 5 times lower. So we can see a huge push on scaling up ART and progress that has filtered down. Now, those are absolute numbers, sometimes referred to as burden of disease. But a very important part of the story rests in these 3 red square images on the slide, which shifted the thinking just about 10 years ago in 2014, when UNAIDS put out this 90-90-90 framework. And I think what's so important about it is it was a shift to talk about proportions, to remember who's in your denominator. So for those of you who are less familiar with it, the 90-90-90 targets were to say that by the year 2020, and remember this was starting in 2014, 90% of all people living with HIV should be aware of their diagnosis. Of those, 90% should be on effective treatment, and of those, 90% should achieve viral load suppression. Now, this model actually extended past 2020 to say that by 2025, which is really only like about a year from now, that the global targets had to meet 95, 95, 95, and all of that was to be sustained in order to achieve HIV elimination by 2030. More recently, UNAIDS has expanded these 2025 targets to a total of 10 targets. This is a bit of a complicated diagram, but I think it really represents a more comprehensive and far-reaching set of targets. And the additional targets are not only for people living with HIV, but they're also for those at risk of HIV. For example, at the very top of the circle, it talks about having those at risk of HIV using combination prevention and having that be 95% of those at risk for HIV. And then it goes on to access to sexual and reproductive health services at 95% coverage to prevent vertical transmission of HIV and others. I will mention that over in the light blue are targets to drastically reduce the punitive laws and the experience of stigma and gender inequality and violence to just 10%. So how are we doing globally? Again, we talked about the absolute numbers before. Here are the proportions. So 86% globally of all adults living with HIV knew their status in 2022. Of those, 89% were on antiretroviral treatment, ART, and of those, a really, really impressive 93% of those on ART had viral load suppression. 3 countries, Botswana, Eswatini, and Zimbabwe, have already achieved their 95 targets. So they did this in 2022, so a full 3 years ahead of the schedule. And another 16 countries, half of which are in sub-Saharan Africa, are close to achieving their targets. So we can feel really happy about the amount of progress that we have seen in the last 20 years. This diagram illustrates PEPFAR's impact by the numbers. I'm not going to go through all of it, and I think perhaps Ambassador Nkengasong will also talk about some of it. But I think looking at the upper left, you'll see a very important number that has been prominent in the news. 25 million lives have been saved through PEPFAR's impact. And ICAP's accomplishments, summarized here in this slide, reflect the work of the very, very many people on the ground and the partners who made it happen. Every number on this slide is a testament to the dedication of healthcare workers at clinics and hospitals, community workers, civil society groups, ministries of health, and the generous support of PEPFAR, Global Fund, and others. The impact of health system strengthening has played an important role in all of these accomplishments. So just for example, at the top, 51 million people have been tested for HIV through ICAP services. 2.4 million have been provided with HIV treatment. 424,000 health workers have been trained, and over 7,000 health facilities and over 7,000 laboratories have been supported with technical assistance. So with all of this progress, let's take a look at number of new infections among adults and children since going back to 1990. And we can see that the curve peaked in 1996. That's when things were really very dire. And they've been steadily improving since then. And I've shown you here on the slide specifically a 38% decline in new infections between 2010 and 2022. And the current number of new infections is 1.3 million. How was this all achieved? Well, in the time that I have, I can't really take you through the tremendous, multifaceted approach to achieving all of this. I can tell you there was no single magic bullet. Partnerships with ministries and communities were absolutely essential. As I've mentioned, commitment at all levels, from healthcare workers in the clinics all the way up to the top, was another essential ingredient. Task shifting was a big innovation. I think for those of us who are less familiar with it, it means shifting the tasks from physicians to nurses, shifting nurses' tasks to assistants in clinics, shifting pharmacy tasks to pharmacy assistants, making use of the people who are there. Evidence-based programs throughout everything, relying on the science, comparing performance to targets, stopping and looking sometimes every day to say, how are we doing? We should have tested 20 more people today. Did we make that target? Surveillance, multiple forms of surveillance and more sophisticated surveillance systems that rely on sophisticated and electronic data systems. Better medications. 20 years ago, people were taking multiple pills multiple times a day, and they had multiple side effects to deal with. And now we have single pill a day types of regimens with very minimal side effects. And of course, with all of this, strengthening of capacity and systems innovations. So with all of these great achievements and all of these great innovations, why are the new infections declining so slowly? Why aren't we doing better? And perhaps more importantly, what can we do to keep going? We have to keep pushing the curve. I'll start by saying that in order to make progress, we have to understand where the gaps are, and that requires continued measurements of how we're doing. And this jigsaw puzzle shows several different ways of measuring. It can be done through modeling, it can be done through recent infection surveillance, HIV case surveillance, program data, population surveys, research studies. Taken together, they have to all fit together and tell us where we are so that we can know our epidemic and guide resources and programs to the geographic and demographic groups most in need. So let's look at some of these data. The population-based HIV impact assessment surveys, the FIA project, conducts nationally representative HIV-focused household surveys to assess the status of the HIV epidemic and the impact of national response programs. Nearly all of these surveys have the same primary objectives: to measure national HIV incidence and to measure the national prevalence of viral load suppression, which is an HIV RNA of under 1,000 copies per ml. These secondary objectives really vary from country to country, and they're numerous, but they all share in common subnational adult and pediatric HIV prevalence measures, HIV drug resistance, detectable ARVs, CD4 distribution. The map on your right shows you the current status of the FIA surveys. It's a little bit of a complicated color coding to just give you an idea of where, for example, in purple, the first survey is being geared up in DRC. And all the way down at the bottom, in the darkest blue color, in Eswatini, which has had a first, second, and third survey. And all of this work has really been made possible through the support of PEPFAR funding. So here's an example of data from the population surveys. And we're looking at the care continuum, that same 90-90-90 framework, for 4 PEPFAR-supported countries that have each conducted 2 FIA surveys. Along the bottom, FIA 1 is the earlier survey, and along the top is FIA 2, a second round of surveys conducted approximately 5 years later. And what I really want to call your attention to are the red boxes. So down at the lower level where Uganda is, I've placed a box to show you the size of the gap in awareness, because that turned out to be the biggest gap. When we started the surveys, I'll tell you, we thought the biggest gap was going to be in viral load suppression. And we were astonished. I actually thought the data might be wrong at first because it was so different from what we expected. But the biggest gap is knowledge and awareness of one's HIV status. And you can see when you look at the top row that that red box has gotten smaller. So it's improved, but it's still there, and it's still the biggest gap of those 3 measures in the care continuum. So there's still more work to do to promote HIV testing using creative measures such as self-testing and other approaches, but that is definitely an area that needs focus. I'll also say, although I'm not showing it to you on a slide, that when we break this data down and look at it group by group, the biggest gaps in awareness, and this is not actually a big surprise when you think about health-seeking behaviors in general, the biggest gaps are among men and among younger individuals. Those are the groups that don't go to clinic, don't seek out healthcare, and so not surprisingly, they have the biggest gaps in awareness. Here's a different take on measuring gaps and looking at declines in new infections. This comes from UNAIDS data that was released last spring, and it reflects substantial progress and some concerns. So many countries along the right are on track and have decreased infections in the last 10 years by 60% or more. Of course, there's a big group of countries in the middle that have seen a decline of between 40 and 60%. And on the right, we see the countries that are doing less well. They've either had a decline of less than 40%, or for a few of them, for example, the Philippines is what's all the way on your right, actually are seeing increases in HIV incidence. So this gives us a global map of where more resources and more creativity are needed. Another important gap is in key populations. This is a term we use in global health to refer to individuals who, through their behaviors, experience increased risk of HIV acquisition. And in this chart, what we are doing is comparing the HIV prevalence among a particular group of individuals to the HIV prevalence in the global general population. So the global general population prevalence is 0.7% as of 2022. If you look at the red circle, you can see that the HIV prevalence among sex workers globally is 2.5%, and that is 4 times higher than the general population. I won't walk you through every number, but you can see as you move around the circle going counterclockwise, you get to transgender individuals with a global HIV prevalence of 10.3%, and that is 14 times higher than the general population. So clearly, these are groups that need a great deal of attention. And not surprisingly, they account for 70% of all new infections as of 2021. Another important gap is in pediatric and maternal child health. In 2022, 18% of pregnant or breastfeeding women, that's approximately 200,000, who were living with HIV did not receive antiretroviral therapy in 2022. And also, again, 2022, only a little more than half, 57% of children living with HIV were receiving antiretroviral treatment, compared with 77% of adults. And of great concern, this gap is widening. Children accounted for 4% of all people living with HIV, but 14% of AIDS-related deaths. So it's not just the treatment gap, it's translating into deaths. At the other end of the age spectrum are older adults who are living with HIV, and this comes from FIA data looking across 13 different countries that showed that 21% of older people living with HIV, OPLWH, were unaware of their HIV status before participating in the FIA surveys. And of greater concern, half of these individuals had never had an HIV test. I think our HIV testing services focus on younger people, and of course there are reasons to do that, but nonetheless, it's important to think at the other end of the spectrum as well. Migrant populations and displaced populations is another area that really is experiencing a gap. Mobile populations are more likely to acquire HIV compared to permanent residents across many different settings. And in Namibia, for example, migration was associated with a lower viral load suppression. So there's a risk of greater HIV acquisition, and then the risk of less well-controlled HIV, primarily due to that lack of awareness of HIV infection. And mobility also increases the risk of HIV treatment interruptions. So I've taken us very quickly through some gaps. Again, we're not covering every single gap. Let me touch on a few threats to think about. And one I want to mention is the coming youth bulge. the New York Times ran a section the other week. They called it the Youth Quake. And it was filled with beautiful photos in many African countries. Here I've selected the population pyramid from Tanzania as an example. Over 60% of the population in 2020 was under the age of 25. That's the red box there. And with Tanzania's high fertility rate of 4.4 children per woman, Tanzania's youth bulge is going to continue. And as these young adults mature and they become sexually active, they are at risk of acquiring HIV if the HIV in the older populations is not well controlled. Another threat is climate change. Here I have a picture of Cyclone Idai from 2019, which wreaked havoc in many southern African countries. I like this circular image on the right, which also looks like, to me, a bit of a cyclone, that demonstrates the impact of climate change on HIV through things like food insecurity, disruption of HIV treatment and services, loss of livelihood, and so on. So it's another problem to focus on. Threats to funding. I'm not going to get into it. I think Ambassador Nkengasong may discuss it a little bit more. But living with flatline funding is a challenge for PEPFAR, given the increasing targets, right? How are you going to reach more people but have flat level funding? And then finally, the last threat I want to mention is equitable access and stigma. One of the UNAIDS targets, as I mentioned before, was to decrease stigma and discrimination by having less than 10% of people living with HIV experiencing stigma and discrimination. The circle on your right shows you countries that have either put in place policies to reduce stigma. That's in blue, the 23%. Some that have partial policies, that's in yellow. And then in orange is the 26% that have not put in place any policies. And I've got a little bit of FIA data for you on stigma, where we looked at results from 4 different surveys. And we found that 9.3% of people who HIV positive adults reported feeling the need to hide their HIV status at a healthcare facility. And an additional 2% reported that they were denied health services because of their HIV status. And how does this translate into something that is, about treatment? Well, individuals who reported experiencing stigma were significantly less likely to initiate ART at all time points, looking back over a 5-year period. So what is the way forward? Well, I'm going to return to the importance of measurements, and there are many kinds of measurements, and I want to just briefly mention recent infection surveillance, that blue piece of the puzzle. HIV recency testing relies on rapid antibody tests that have been developed to determine if a newly diagnosed person living with HIV has recently acquired their infection, as in the past 12 months. And I've got an image for you of these very simple to use recent test strips. Want to just mention some of the caveats because there have been concerns, but recency testing doesn't generate HIV incidence estimates. It won't identify all recent infections, and population level patterns and temporal trends are what we need to help guide programs. And really what the bottom line here I'll say is that it complements other forms of surveillance. And there are no other forms of surveillance that will identify the leading edge of the epidemic. Can't do FIA surveys every year. So recency testing has a role. Continued treatment as prevention to reach 95, 95, 95, not just globally, but in all populations is essential. There are many, many ways to achieve this. I've put the syringe there on the slide to say that injectable antiretroviral treatment is coming. There have been a series of demonstration projects that reveal implementation of injectable ART has many complexities, but I think it's something that we can work out. Another approach to expanding treatment is to rethink HIV service delivery using person-centered, differentiated service delivery. We're going to hear a little bit more about this during our panel, but this is saying we're not going to just stay with the one-size-fits-all public health model, but say, who are we taking care of here? What is the best way to give them services? What's the where? Should we give them their services in a clinic or somewhere else? What is the what? Should they have treatment? Should they have HIV testing? What is the who? Should they get their services from a community worker? And what is the when? Do they need to come in every month or should they come in every 6 months? Here's one example, and I'm going to move quickly because we are running out of time, but there are many different models of differentiated service delivery. Here's one for mobile populations that's all about meeting people where they are. And with climate change, we have to be ready to adapt to that. For example, giving 6-month supplies, MMD is the jargon term, during the rainy seasons, using drones to supply antiretroviral medications to remote locations after a climate event, and storing medical records on cloud servers, something that some ministries of health are really not comfortable doing, but once they're on a cloud server, they can be recovered after a climate event or other type of event. I want to briefly mention 3 types of pre-exposure prophylaxis: oral PrEP, the dapivirine vaginal ring, and cabotegravir, long-acting injectables. These are now all approved. They're available. The oral PrEP is quite effective, less discreet, requires taking a pill every day. The dapivirine ring is moderately effective, more discreet. You have to use a new ring every month. And injectable cabotegravir is highly, highly effective, very discreet, but it requires an injection every 2 months. Cabotegravir was evaluated through some research studies, HPTN 083 and 084, and at ICAP we're quite proud of the role that we were able to play in contributing to those studies with our research sites in New York and in Eswatini, helping to develop it. This is just a map to show you that the approval of long-acting cabotegravir as PrEP is now available in multiple countries. That's the blue color. And in yellow, that's where approval is pending and is coming very soon. And in red, it's going to be submitted. So that's only Canada and the UK. There's a very big prevention pipeline, lots of things on your right that people are developing. So, our summary. We have made progress with global targets, and we've done that through a very broad set of programs, program targets, data systems, partnerships, better medications, and strengthening capacity and systems. We've talked about the persistent gaps and threats. I don't think I'll repeat that for you. I think you can see on the slide. The way forward really must accelerate prevention. Last evening, Angeli talked about the importance of perspective and persistence. And I will add the 3rd P of prevention. And prevention has to be that global view of prevention. It has to include treatment as prevention to reach 95, 95, 95 in all populations. It has to include broader access to biomedical and health delivery innovations, youth and key population friendly services so that when you walk in the door, you're not greeted by a scary matron, but you're greeted by somebody perhaps who looks like you, who is your age, who is friendly, and will help reduce stigma, and differentiated service delivery methods. Thank you very much.
Well, thank you very much, Jessica, for this wonderful presentation. And please do remember to jot down your questions so we can get to them at the end of the session. At this point, it gives me great pleasure to then introduce the moderator of our first session today, and that's Ambassador John Kingasang. And as all of you know, he's Ambassador at Large, U.S. Global AIDS Coordinator, Senior Bureau Official for the Global Health Security and Diplomacy, and has been a key leader for years and years and years in the HIV response. And we're honored to have you here today, John, with us to moderate this first session. Thank you.
Thank you, Wafaa, and Jessica. What an exciting, illuminating presentation. So the session that follows would tie in very nicely with what Jessica just presented, and we are truly fortunate to have a group of 5 experts that will present very short overviews, or what I call a response to what Jessica just presented. And I'll invite Angeli Achrekar to come over here. She is, as you know, as you walk over here, many people here know Angeli. She used to be at PEPFAR, but is now the Deputy Executive Director of the program at the UNAIDS. Angeli, please take a seat. Rosemary Nyirenda, whom we were last night together from, she's from Malawi, is the Director of the National HIV, Viral Hepatitis and STD Program for the Ministry of Health of Malawi. Rose, please take a seat. Peter Ehrenkranz, who is the Deputy Director for the HIV program at the Bill and Melinda Gates Foundation. Peter, please. Solange Baptiste is the Executive Director of the International Treatment Preparedness Coalition. Good to see you. And Miriam Rapkins is, good, I thought I saw Miriam, is the Director of the Health Systems Strategies at ICAP Colombia. So, what we will do is I'll bring this remote with you, and you have your 3 slides. You just go over that, then we'll do the questions. Then I really hope that we'll open up for an engagement with the audience as well as we go through your presentation. So, over to you.
Great, thanks so much. It's and is this how I advance the slides?
Yeah, the
big button.
The green,
okay,
yes.
Great. Oh,
yeah,
goodness. Okay, let's change that. Okay, yeah. There we go. Thank you, Ambassador. It's wonderful to be with you all today, and a real honor and privilege to be on this panel with esteemed colleagues. Really just want to first acknowledge and celebrate ICAP. It's great to be with all of you in the room and celebrate the what was described last night powerfully as the power of global partnership, which ICAP is very much a part of. I wanted to quickly go through 3 slides. So the lightning round, and Jessica presented some of this because these came from UNAIDS data, but I just wanted to ground us all in this slide. Dean Freed talked about hope and scale. This is an example of hope and scale that you all have contributed to over the years, over the past 20 years. In the slide, we see on the left, on your left, new infections that have dropped by nearly 60% since the height of the pandemic, since the height of their peak. And on the right, AIDS-related deaths that have dropped by nearly 70%. This is extraordinary. That is without a vaccine, without a cure. This is collective work and global partnership, and that is really astounding. And some of this was showed in Jessica's presentation earlier as well, but just to say, when we look broadly, globally, at achievements and progress, on the left we see the treatment cascade, and we really heard about the powerful gains that have happened over the years, with now nearly 30 million people on treatment. And again, congratulations to ICAP for having 2.4 million people on treatment of this amount. It's really, really remarkable progress. But what you see in orange is just a comparison to green in 7 years' time, just what a difference we've made. Incredible progress in the treatment work that we've done globally, and very strong progress in HIV prevention as well. Of course, we still have 1.3 million new infections that we have to drive down, but we should also celebrate the progress that's been made, particularly in high-burdened countries in East and Southern Africa. One thing that I do want to note is that we often talk about global progress, but it's important to realize that every country of the world, 193 countries, have signed on to these global targets. We talk about, sustainable development goals, but these are goals of countries that they have signed on to, and the progress that countries are making. Of all the 17 SDGs that exist, the only one that's actually making progress is SDG 3.3, and that's tremendous, and that's because of the HIV response. And the final slide, just to share, and we heard a lot about this in the previous presentation, this is the report that UNAIDS put out last summer with all of the data across the globe. But there are real exciting, promising data that are coming out that we've shared and that were shared earlier. And there is a path that ends AIDS. And there are countries like Malawi that are on that path, really progressing so far. And we know that it takes partnership. It takes bringing prevention and treatment, evidence-based interventions to scale. It takes data, guiding resources where we should invest, and it takes tackling equity and inequalities so that we can ensure that every population that needs the services get them. So I will stop there. Thanks, Ambassador.
Thank you. Just pass it on to Rosemary. I'm sure the slides are arranged in that format. So Rosemary, take it, run with it. Just the green, yes.
There you go.
Thank you very much, Ambassador. I think as Malawi, we are very humbled and honored to be part of this celebration, but also just to be featured on the panel. So thank you, Wafaa and team, for considering us to share our story. I think the background, which I had on my slide, has already been shared, I think yesterday and even today. Malawi is a country in the sub-Saharan Africa, and this is the region that has made significant progress in terms of reducing new HIV infections. But we are also increasingly achieving the 95s, but we are off track. We are off track when it comes to ending new infections. I think this has been highlighted by our colleague from UNAIDS. In terms of Malawi, our population is growing. According to world population projections, in 2022, we are at 21 million. We have 1 million, approximately 1 million people living with HIV, and I think yesterday I did mention that at least 930,000 are alive on ARVs. And our prevalence is at 7.7%. This is according to the 2023 Spectrum estimates. Let me mention that in Malawi, services are free at point of service delivery in public health facilities. I think this is worth noting, considering the topic or the theme that we are addressing today. But also what struck us this year was that half of the cohort of people that are on ARVs are in cyclone districts. And this is an area that is a big threat because if we lose out this population, assuming their ARTs are interrupted, that will take us back. There's rapid population growth, but also urbanization. This can also be a risk, considering that the most population are the youths. And we have also noted that the high population density is a predictor of high HIV prevalence. We have made achievements. We are a low-income country with global partnerships. We have made a lot of progress. We already reached epidemic control in 2019. Our reduction or decline in new infections continues to be stellar. And this is largely because of the strong care and treatment program. And the incidences, as I mentioned yesterday, is less than 0.03% in 12 districts, and even lower in the rest of the 29 districts. And again, attributed to strong care and treatment program. We continue to reduce deaths. There's still more work to be done on that area. And for the 95s, we are closer to reaching the 95s, but not for children. We have got very strong data systems, and we use these systems for cost effectiveness of interventions and prioritization of investments. We have attempted to make sure that we invest on interventions that are going to give us the most impact. What are our priorities moving forward? Obviously, we've made all the gains that we have demonstrated, and we need to sustain them. We need to continue testing to fill the gaps. We need to retain the 900,000 plus to make sure that all of them are virally suppressed moving forward. And this is a challenging area. I think viral suppression, viral testing alone is a major undertaking. I think as we proceed moving forward, we are going to learn a lot of practices that probably as a country we can start introducing funding for that. We need to close the gaps. So what are our gaps? I think in the slides, just like other countries, the 95s in children and men are our focus areas. Vertical transmission, we want it to be less than 5%. We want to increase service coverage for key populations, but also advanced HIV disease. We want to expand access to new tools for prevention among the high-risk populations. But also, HIV is becoming chronic disease. So we have a cohort that is above 40 years that we should be managing. They are going to live longer, and NCDs are going to be an issue that we have to manage. Now, as a country, we recognize that we have been hugely depending on external funding. All ARVs that we give to the 930,000 people are externally funded, and that's a big risk. But also with the climate disaster issues that we have experienced, as a country, we developed a new health sector strategic plan 3, the Malawi Health Sector Strategic Plan, whose theme is reforming for universal health coverage, but also the achievement of SDGs by 2030. We launched it this year. It runs from 2023 to 2030. And in this strategy, we looked at what is it that we can offer to Malawians? What minimum package of services can we offer that we as a country can manage to fund even without domestic resources? And what will the path look like for us to get there? So it's a different way of doing things altogether. It's about reforming a number of aspects of how we deliver our services. So the strategy has reform areas. And these are the reform areas that are going to take us through with the HIV response, with the sustainability agenda for the HIV response moving forward. So those reforms, which are a number of them, there are 10 of them. I will not mention them. One of them is integration, but you can refer to our health sector strategy plan. It's available on our website, on Malawi government website. So for us to implement these reforms, we discovered that we needed also to come up with a health financing strategy. So we have the health sector strategy with reforms, which is going to move together with financing. And the financing looks at opportunities for domestic resources, both from government, but also how government can generate resources differently from previously, like introducing medical insurances, but also the role of private sector. I will not touch on that, but just to mention that the reforms several of them, and one of them is integration, which I'm going to focus on. So integrated health systems approach is one of the key areas. I think that is going to impact on how we deliver services. The other reforms are equally important as well. Issues of human resource, issues of how we come up with value for money for our integrated platforms regarding diagnostics. There are areas of the roles of community, the actual domestic finance. So there are about 10 reforms. But the integrated health systems approach is I think, an interesting area for us in the HIV space. And the fact that we are taking HIV now as a chronic disease, from the integrated platforms of care that we are going to develop, it's now transitioning from HIV exceptionalism to integrating with the rest of the services that form the health care package. So what are the diseases in the health care package? HIV is one of them. There's TB, there's malaria, there's nutrition, and NCDs. These are the major disease burden areas that are affecting Malawians. So moving forward, these reforms will be aligned to the HIV sustainability agenda, and we are using the integrated health systems approach. And again, in these reforms, we are also going to invest in primary health care. And in the primary health care, we have tried to incorporate health care workers that are very strategic in terms of the issues that we are seeing with HIV. For example, retention is an area that is very key. We have to retain the 930,000 plus in the next coming years, 5, 10, 15 years. And we need a strong primary health care component where health workers, for example, psychosocial workers, are part of the health cadres. But we also need a cadre of community health nurses because most of the infections are in women in the childbearing age. So if we are going to tackle women in the childbearing age, and including even adolescents, then we have to make sure that we go into the reproductive health, maternal, newborn, child health spaces with our HIV interventions. But we also know that we are not doing well when it comes to coverage of services for key populations. And we wouldn't say that key populations would be covered within the public health services. Yes, we are covering some of them, but not all of them. So there has to be a separate approach when it comes to key populations. Yes, those that can attend services within the public health system, they should be able to attend, but there are those that we may have to create safe spaces for them. So it will be a combination. We're envisaging a mix of vertical and horizontal approach in service delivery. But also investment in resilient health systems that can withstand health shocks is very key. I think we've seen from the slides that Jessica presented, we have to do things differently in the cyclone districts. Month prescription, yes, but probably even much more beyond. We have to innovate. We have already started planning as a country because we know January, February, those are the months we get all these cyclones. How are we going to manage those districts, particularly the HIV response? This is already on our table. But also we cannot be able to move forward without genuine.
Rose, I will ask that you begin to conclude so that we'll come back with this for you to expand on subsequently.
So we are supposed to journey with communities moving forward. Thank you.
Great. Peter, over to you. Just for the panelists, there's a lady over there. Please watch that angle as you make your remarks so that we have time to discuss and interact with the audience.
Good morning, everybody. It's a pleasure to be here. I've had the honor of partnering with ICAP for maybe 15 years or so at different points from different positions in professionally and also personally. So it's just an honor to be here and to celebrate this 20th anniversary milestone with you. Also an honor to be on this panel with you all. Some of you I don't know if I've ever met in person, but it's certainly interacted with you many times, and others of you I'll be seeing all week. So it's great to start off this way with you. I'm going to dive a little bit deeper. I think we got some nice really lovely overview from Jessica, and then the point of view of UNAIDS, and then down to Malawi, and then I'm going to go in at sort of a cross-sectional issue across countries. Our remit was to say, what do we think needs to be done to control the epidemic? And I just wanted to pull out some unpublished data, actually unpublished on the left, published on the right, to point to a sort of a different side of the story. Jessica really emphasized the importance of finding those people who are undiagnosed, and that is certainly a critical part for the epidemic. But others throughout the morning's presentations have really emphasized the idea that what you see on some of that high-level data when you're looking globally or even at a country level can mask what's happening in subpopulations. And my point here is that there's a subpopulation of people who are ART experienced, who those people, as we're moving forward, are going to be more and more important, particularly in countries like Malawi that are so close to being at this 95 level. Those are the people who are going to increasingly be the source of the new infections. So on the left, you can see this is unpublished data from Eswatini, showing the incidence of the epidemic starting in 1980, and the green bar that's up at the top there, or the biggest one, that's latent. And latent here is defined as people who are HIV infected and who have either never been on ART or have dropped out of ART. And then the purple, which is the next bar that's sort of starting to overlap as we get to that red arrows where we are in 2023, that's the people who are on ART, people who may not be consistently taking it, who may have dropped out of care and, because of their own issues, or maybe because the system, and that's one of my emphasis, the system is not helping them stay in care. On the right, just to complement this is published data from a group out of University of Cape Town. This is old already, it's 5 years old, but you can see the same trend. Those lighter bars on the top are the people who were previously treated or people on ART. Those are more and more the sources of new HIV infection. So a few years ago, a group of us published this, in theory, cyclical cascade, and we're building on other people's work. I don't want to say that we dreamed this up out of nowhere, but the idea here is that the linear cascade that Jessica put forward earlier, and actually we've seen in other slides, of that sort of a conceptual model of somebody gets diagnosed on ART, somebody gets on treatment, somebody gets diagnosed with HIV, somebody gets on treatment, and then they stay on treatment for the rest of their lives. Any of us who have ever participated in medical care, I think we can be aware that that's not really how this works. We all sometimes are very good about attending to our own medical needs, and other times we are not. And even if we are really determined to take our medicines, if we're in a position where we have to take medicines every day, sometimes we have to travel. Sometimes we can't get that prescription refilled. Sometimes we have an unexpected event that happens and it's just not on the top of our minds. And that's what this diagram on the left is documenting, that people maybe at any stage in the course of care, they may drop out, but also that they were likely to re-engage. And that's one of my messages, is that if we give people a chance, the majority of them will come back to care on their own. And that's actually what you see on the top right. This is also unpublished data on the right. This is really unique data. It's from Western Cape. This is not a study. This is the data from the data system in the Western Cape province of Cape Town. So all 600,000 or so people in the Western Cape are captured in the system. They can press a button in their data system now, and somebody was emphasizing the use of data. They can press a button and update this data for today. So what the upper right shows that ART experience at initiation, how that has changed from 2017 on the left to 2023 on the right. Even in 2017, there were 50% of the people were ART experienced who were reinitiating care. But as you get to 2023, this is after COVID, after the big push for treat all, as we say, sort of a rapid access to ART. You can see that now twice as many of the people, for every one person who is starting ART from a naive point of view, another two are starting ART from being experienced. They're cycling back into the system somehow. For a more granular look at this is on the bottom right. I always find these diagrams confusing. It's called a Sankey diagram. Just bear with me. On the left side, this is July 2022. So in July 2022, there were 58,000 people that were in that early ART bucket. They'd been on treatment for less than 6 months. There were 281,000 people who were in the long-term ART bucket. If you move over to the right, that's 12 months later. you can see if you just track that 58,000 people from early ART, you can see some of them are still in early ART. They probably left and they came back. You can see a number of them actually got re-diagnosed. Some of them died, unfortunately. Some of them are I can't even read that anymore.
Linked to HIV.
Linked to HIV care. So they're sort of early on in the system. Thank you. I have to get my eyes checked. And then importantly, you can see that of that 58,000 who are on early ART, about a third, somewhere between a third and a half of them actually disengaged. Same thing from long-term ART. I'm not going to go through it in the same level of detail, but you can see about an eighth of the people that were in the long-term ART bucket disengaged 12 months later. Now, if you were trying to use your resources well, as we all are, you could easily say, oh, it's the biggest group is coming from those who are long-term, the biggest in numbers are coming from the people who are the long-term ART. We need to focus on those folks. However, relatively speaking, the biggest proportion is coming from the early ART group. This is you can mull this over, but the answer is we need to focus on both. Hopefully, public health mindset, we need to turn off the tap, turn off the leaky tap so that, or plug the hole in the sink, right? You have your choice. You need to go as upstream as you can, and maybe you even can figure out who the people are who are likely to disengage and prevent them from disengaging or offer them another model of care. That's what I'm going to get to here, so that you can hopefully slow the loss. However, we still must recognize that engagement and re-engagement is a natural part of many clients' journeys. And here's a list of things and things that we should think about. One is, as already been mentioned, is can we provide people a model of care that suits their needs, not the model of care that suits the health system's needs. And there's been a lot of progress on this, and I think Miriam will talk about it more. Amongst the things on the lower bullets, I want to prioritize other things that the system can do that are maybe, and those of you who are more on the front lines can talk about this, maybe easier to do. One is make it easier for people to collect and provide emergency refills. It turns out that if you have to go somewhere else for work, for a family event, for a cyclone, it is hard to show up at another clinic and say, hey, I'm on ART. Can you give me a 1-month refill before I get back to my home clinic? A lot of places won't give it, or they'll make it a real hassle. They'll treat people really badly. Can we make this easier? And I know that in Malawi, that they're starting to think about how to make this work. Another one is easing the client and facility level administrative requirements on temporary or permanent transfers between facilities. It's just a fact. People don't like to ask for a transfer order sometimes. They don't want to go back to the doctor and say, hey, I'm moving, it's hard. They'll go to the nurse. It takes time out of their day that they don't want to spend doing that. And even if they do that, there's not always a system for them to do it. And it becomes a real hassle. Can we make this easier so people can come back to care more easily? Then on the last one I'll call out is innovating new means to identify and serve people at risk of disengagement. This is the wonders of AI or machine learning. If you have a data system like the Western Cape, can you go into more granular detail and say, oh, it's not just young men who are at risk of not coming back to care. It's young men who live in this particular district, or it's young men who live in this particular district who get paid on Fridays, and therefore you spend all their money doing this and they don't want to come back to care on Mondays. And can we shift the day to get their care or the location they get their care? Thanks very much.
Good, just please take it on with it.
Great.
Solange.
Hi, everyone. My name is Solange. Nice to see you all. And thank you again to everyone for inviting me, ITPC, to be part of this panel. I think I'm one bringing a community perspective. So I'll jump right into it. So in reaching HIV epidemic control, things are not always what they appear to be. It's my attempt at a joke, right? Get it? All right. I mean, it's also the wonders of AI where you can go to DALL-E and be like, give me a pear with a citrus on the inside. Anyway, I'm preaching to the choir, but the point is here, things you already know. So you may think that you may have achieved, and by population, you are masking other things. So Peter talked about those who were ART experienced, but here you're looking at 5 countries that reach 95, but not across populations. Probably can't see the detail too well, but the bigger bigger picture is the more important thing. And inequalities towards the 95s, you see when you unmask the adult population, you will see a different picture, a different story. So the path to progress means elevating community data and community-led interventions. That's what I want to say today to this group. I think we know all the traditional public health things, but I want to just re-emphasize the importance of the community perspective. We normally have sources of data. If you want to understand what's going on in your country, you'll find it from a survey, medical record, claims, records, surveillance, literature. And you normally go to the government, and the government is often looking at what's happening in some research project or academia and projects, and within the health system itself. And there you can find information from clinics, hospitals, the private sector, also the labs, and that will feed into what we understand to be what's going on in a country. And then, like if you're sprinkling icing on a cake, you get a little bit of community stuff. You get some anecdotal evidence, you get a little quote, you put a picture of somebody that looks happy, that was once sad, you know how they do it. And then, but at the same time, we've been doing this, and this is the achievement slide. Anyway, maybe I didn't do that right. There are persistent issues with how we've been doing things traditionally, and these things are the lack of granularity to decide decision making, and I think that's going to be increasingly important as we have shrinking fiscal space, less money, tighter budgets, and you still have to serve many, many more people. And so you need to have more specific interventions to be able to make your money work for you. Inconsistent and often low quality of services. We have discriminatory laws and stigma, prohibitive prevention and treatment pricing, and the shrinking health budgets. So I'm putting forward that there are 5 priority issues and proposed solutions that communities really want to bring forward. Community data. It's important, and it's important from a triangulation perspective, whether or not you believe the data is the most robust or reliable. You need to kind of hear what the other side is saying, and if there are big gaps, then you need to say, well, maybe we should check again. In terms of human resources for health, I think this crisis is very much linked to the quality of service issues and back to that cyclical cascade cycle. And I sound like a broken record for people that have heard me before, but think we should invest in effective management. I'm talking about basic operations in HR. We have this sort of notion where it's better to have at least a rude nurse than no nurse. I don't think so. Because in any other space, if you were rude, and we know there are lots of studies that talk about how far people will go and how long people will wait in order to find good care over rude care. And if we don't actually adopt better, effective management strategies and get the evidence to show that this will translate into better health outcomes, I think we're going to be stuck on this human resources issue. Bad laws kill, I think we know that, but we don't have funding for advocacy. So we could talk as much as we want, but if civil society is not able to make that pressure on the system, we're just talking to the air. Prohibitive pricing for health, we need to talk about local production, and we need to talk about getting those prices down and to deal with monopolies. And shrinking health budgets, there's this global public investment concept of all contribute, all benefit, and all decide, where there isn't this donor-recipient mindset where, like, please give us some money, we are a poor country. And I really love to always hear Rose as she talks about, Malawi taking on its own reform and its own domestic financing and how these things can marry with each other. So the path to progress means elevating community data and community-led interventions. I keep repeating that. So here we are. If we take away these persistent issues and we put in affected communities, we could look a little more like this, where we make space for community data and affected communities inputting into the whole picture. So here we get a whole data picture, we get triangulation, and we can actually get advocacy for the things that need to get done, but within the clinical research space, that's not what you're going to be able to affect change at. And this is my last slide. At the Paris Summit, and this is from Mark Justman in the Foreign Affairs article that he wrote recently a few months ago. It's called The Root of the Global South's New Resentment, How Rich Countries' Selfish Pandemic See, now I can't even read. Responses. Stoked distrust, of course. I was just testing your eyes. All right. Well done. All right. At the Paris summit, the Kenyan president, William Ruto, said, African countries long to be perceived as part of the solution for global problems, not a drag on solving them. If rich countries shed their perceptions that low-income countries remain mere recipients of their charity, they would find strong allies with the expertise to help take on some of the most persistent health and climate challenges. What I want to say here is communities also have the same issue, and it's just a different scale. Communities long to be perceived as part of the solution for global problems, not a drag. If we shed our perceptions that communities remain mere recipients of charity, they're a drag on the system, we have to help these poor people, then you would find strong allies with the expertise to help take on the challenges. So I would say the future is community-led. Thanks.
Yes, Miriam.
Thank you. Thank you, and it's a pleasure to join this esteemed panel and to listen to my colleagues. As we've discussed, achieving epidemic control means more than discovering which HIV prevention, testing, and treatment services are effective. It means actually delivering these services at scale and with fidelity. Implementation science, or some people say delivery science, can help us to understand how best to design programs that reach people. We need to stop talking about hard-to-reach people, and we need to start talking about hard-to-reach health systems. In the past 6 to 7 years, evidence has shown that a strategy called differentiated service delivery, or DSD, that many of my colleagues have mentioned, is a winning approach to reaching and retaining more people in HIV programs. DSD is an implementation strategy that typically simplifies and adapts HIV services across the prevention, testing, and treatment cascade to reflect the preferences, expectations, and needs of people living with and vulnerable to HIV while reducing unnecessary burdens on the health system. And as Jessica mentioned, it requires us to step back and look with new eyes at the where, who, when, and how of health service delivery. A growing evidence base supports innovative and person-centered program designs, and these are just a few themes, not models themselves, but the ability to de-link clinical visits from drug pickup. I may need to come see a clinician twice a year or 4 times a year, depending on what my health status is. Do I really need to come every month to pick up my drugs? Do I need to come at every clinical visit? Does that mean a drug pickup visit? It really doesn't. It means developing community-based and community-led models, as well as facility-based options for HIV services. It means offering choices between individual models and group models, and also shifting to multi-month dispensing for people doing well on treatment. So to take one perspective on achievements and progress in this space, I'm going to talk about CUNY, which is a learning network. And just to start by saying that DSD models have often been designed with and by recipients of care, who are people living with HIV and engaged with the health system. As the research evidence began to show the impact of these innovative models, small pilot projects and medium-sized pilot projects sprang up around the world. There was sort of an explosion of creativity. But the next challenge was taking this approach to scale. And in an effort to accelerate the scale-up of these strategies, the Bill and Melinda Gates Foundation funded ICAP to lead the CUNY Learning Network. CUNY stands for Coverage, Quality, and Impact Network, and at the moment has grown to a 21-country African learning network, which is, as I said, designed to accelerate the scale-up of high-quality DSD by fostering partnerships, country-to-country learning and experience sharing. The network centers ministries of health and people living with HIV, as well as development partners, and includes a large variety of ways for individuals and country teams to share experiences, best practices, resources, and tools. Since 2017, CUNY partner countries have made rapid strides in scaling up and diversifying DSD serving a wide range of communities and populations in a very wide range of settings. And in an external evaluation, stakeholders reported that CUNY was one of the most important contributors to DSD implementation and scale up in their countries. So I just want to take the moment not only to highlight DSD, but really to highlight peer-to-peer learning, country-to-country exchange, and again, getting away from this idea of technical assistance as something that only comes from one direction, from the north to the south, for example. So in terms of priorities and way forward, priorities for the CUNY network are in reflection to some of the imperatives that Rose and others have mentioned. We're expanding the scope and focus of the network to include differentiated HIV testing services as well as differentiated HIV treatment, and also to expand emphasis on models that provide more holistic, person-centered care for people living with HIV. So back to Rose's theme of integration. So a lot of the partner countries are working together to think through how to integrate non-HIV services into HIV programs, whether that's family planning or TB prevention or services for non-communicable diseases like hypertension or diabetes or mental health services. In addition, I think another priority is to leverage the lessons learned from DSD for HIV to inform how we deliver services to people with other health challenges, including some of these non-communicable diseases. So there's a lot to do, and we're looking forward to the next 3+ years of CUNY and to continuing to share the progress we're making together. Thank you. That was his.
Okay, so let's do very quick process control. How are we doing on time? 20 minutes, great. So I promised that I was going to come back with a round of questions. So I really like us to devote the next 10 minutes to go back to some of your remarks. And we allow the next 10 minutes for an interaction with the audience. So that means I will credit anyone who keeps their answer short. And if you do that, I will reward you by a second question. So let's start with Rose. You talked about HIV exceptionalism and the need for integration. If you can just expand a little bit on that, how do you see that as part of the sustainability program for Malawi?
Thank you. As I mentioned, we have a number of reform areas. There are about 10 of them. And one of them is integrated platform for care, whereby services will be provided in an integrated way. And we are going to develop components for each of the set of high disease burden areas in terms of how we are going to do the screening and diagnosis, prevention and dialogue, treatment, rehabilitation, and all those components. So we are developing those packages of care at the moment so that we can be able to integrate, including HIV. Of course, for HIV, because of its previous exceptionalism, there will be adaptations that will have to fit HIV. This is a strategic perspective, but when you start unpacking it, we want to make sure that those components that have been prioritized within the integrated systems fit within our HIV space, because we don't want to lose the gains that we've made. But also let me mention that the reform areas, there are reform areas that will affect all priority diseases. But for HIV, we have also started adapting to make sure that they fit what the HIV services will look like now and beyond. I mentioned that one of the gaps that we have is the issue of 95s for children. For us to get the 95s for children, the community response has to be strong. The facility response have to be strong. And we need additional cadres of health workers that may not be there at the moment. Psychosocial workers are one cadre that are not there. So These are pieces that we are trying to fit within all those reforms to make sure that as we move forward with HIV, those reforms are going to incorporate the HIV needs for us to sustain the gains moving forward. Thank you.
Thank you, Rose. And that's a very good segue to come to Angeli and share some reflections on this year. Actually, you launched the UNAIDS was critical in launching the Global Alliance to End AIDS in Children. And you just said, Rose talked about the 95% for children, the gaps that remain. If you could just expand on that, what do you want to achieve with that? And I'll do something unusual, which I asked you to comment on a comment from Rose, which she talked about HIV exceptionalism. Do you think by using such a word, we are making ourselves vulnerable to the success that we've seen in HIV? Because the word exceptionalism looks like we're trying to be something different from, rather than building on the progress that we've made, especially in children.
Thanks so much, Ambassador, and I'll try and be brief so I get the present of having another question. 3 points. One, it is unacceptable that we're still in this space where children are nowhere on the map related to the treatment cascades that we've seen. Solange showed it in her slide where we saw the breakdown of the treatment cascade by men, women, and children. The blanks were for children. Nowhere. They're not on the map. That in this day and age, with the progress that we've seen, unacceptable that children are lagging farthest behind on the treatment cascade, full stop. So we heard from Rose, we heard what this really means at the country level. Enough's enough. So the need is there. Second point, that is why we, with PEPFAR, Global Fund, UNAIDS, UNICEF, and WHO, along with 12 different countries, launched the Global Alliance to End AIDS in Children by 2030. That is a movement, really, to bring the political leadership from the country level to focus in on children and to close those gaps. But also importantly is it brings, and I want to thank PEPFAR and Global Fund, because what you've done is also bring resources through your country operational plans and Global Fund through their grant cycles to focus attention with the countries on countries' plans to address children. So political momentum, financial resources, and commitment to do this. We need more partners. We need, and I'm excited that Gates Foundation and others are joining in, because we need to close the gaps, not by 2030, but by 2025. We just have to do it, and I think we can get there. The third point, and so we've launched this global alliance to end AIDS in children by 2030, but again, we're trying to surge fast to get there by 2025 in a really focused, deliberate way. The third point about HIV exceptionalism, you know, I think we in the HIV community, all of us here and all of those that we represent at country and community levels, I think we have to be thinking about how we are not different, but how we have something that we need to, it's been an amazing experience that we've had, and how can we build upon that, continue to respond to the HIV response, so that we're not excluded from what's happening in the rest of the world. We've got to be able to make the connection between how HIV actually provides the lessons, whether it's governance structures, data and how data are used, how communities come together in a multi-sectoral approach, how we bring resources and political will to make a change. I think these are the lessons we've got to bring to the broader world.
Thanks. Thanks, Angeli. Solange, let me come to you about your very thought-provoking remarks about community. You've called community-led monitoring the crucial countermeasure for current and future health threats. And I know that includes HIV, but it's not limited to HIV. What is needed to take CLM to the next level, in your views?
So I think that we have spent maybe the past 5 years or so trying to prove that community-led monitoring is technically sound. Because it has often been it's been met with, it's community data, can we trust it? Is it representative? What can we do with it? But I think we've shown now that it can pinpoint issues faster, and it can also serve to produce solutions at a local level, especially local data for local change. What we need now is the political feasibility. I think because it has not been scaled with fidelity across the globe, CLM can sometimes show up, or people or governments can experience CLM very differently. It's like that, that relative that you see and you're like, you think he's a good guy? No, I think he's a bad guy. Because some people think it's like finger pointing. You think, no, we have to keep these guys out. And some people see it as oh yes, welcome in, you're part of the solution. So I think in order to get that political feasibility, we have to do work to get the political capital there. Win-win. What is the investment case? How can governments support accountability mechanisms even within their own country? I think we have this pervasive notion, and we just keep this narrative going, that governments will never support communities to hold them accountable. I think we should question that. I think if it's done really well, we can see that there's a specific kind of partnership between communities and civil society and government that can actually solve this problem. And I think community-led monitoring and, in fact, differentiated service delivery linked with that is a very neutral entry point into getting that work done.
And just a follow-up on that, one of your slides, you talked about the granularity of data. How can your community, how can community-led monitoring fit into that or help us get into the granularity of where we need to be? And that is something Peter also highlighted, to go beyond the numbers and see the sub-levels.
Yeah, so one of the ways for us to get data sources is through these surveys and population level surveys. But if we're serious, like we're talking about the reality of like Rose, if you're thinking about the cyclone and the shrinking health budgets, we have to do more with less. And I think the way forward in the future is not expensive population level surveys. We need quick data. And because CLM and community-led interventions often start at the point of their lived experience, what is the pain that you're feeling? Let's go figure out the problem and let's innovate a solution, fail fast and try again, and intervene at a local level. I think you can get to that kind of granularity that we're looking for, and that's high impact and low investment.
Thank you. So, Peter, you called for a shift in the way that we think about HIV cascade, from a linear progression to a cycle of engagement and re-engagement. Can you describe a few examples that can promote the re-engagement approach?
Sure, and I'm just going to pivot from Solange's a project that we supported in Zambia was specifically about trying to engage recipients of care, people living with HIV, to understand more about their experience and why they may or may not be taking their medicines, adhering to care. Obviously, if you go to a clinic and the nurse is rude to you, or if you try to go to a clinic and that's too far away, or any other barrier, that's going to affect your experience of care. And so what the organization is called CIDRS, what CIDRS did is they routinely surveyed the patients that were receiving the care, and then they also did what they called trained expert clients. They basically gave people a 15-minute sort of training of how do you pay attention as you're going through your normal routine patient care experience. And then on the other side, they interviewed them again and said, what did you see? What did you experience? And then they put this data into dashboards and brought it back to the facilities and said, hey, I know you're spending a lot of time looking at your clinical data, your retention data, your viral load suppression data, and so forth, but here's a new stream of data that we think is also important. And they actually were able to show by just, somebody mentioned, it might have been Jessica, quality feedback loops, and also you mentioned management. This is a new management tool, not an expensive one to collect actually, that led to, and it was a randomized controlled trial, led to improvements of retention among people who we know are at most risk of falling out of care, which is, it was people who are newly initiating, and it was people 20 to 25, young men 20 to 25. And by making the care more empathetic, by alerting the nurses to, hey, this is what patients are saying about their experience, and trying to put the nurses, and for those of you who are healthcare workers, I'm a doctor, I can say this, those of us who are medical workers, sometimes we forget what it's like to sit on the other side of that table and to remind the healthcare workers, hey, that could be you who couldn't come to your appointment. That proved to be very effective in this circumstance. That would be my one example. There are others actually from Malawi about welcome back programs, about changing the systems of care to make it easier to get emergency refills that are particularly important for people who are mobile. And I think Jessica and also others mentioned here the importance of people move. Life happens. And those are important examples as well.
Great. So, Mira, let's turn to you before we go to the audience. Can you describe a few examples of country-to-country learning within the networks that you mentioned, and why do you think these approaches can be more effective?
Absolutely. So one example of country-to-country learning is actual country-to-country visits. So it might seem a little like extravagant,
and
actually.
The country-to-country visit is who? They're like Rose going to some.
Yeah.
Okay.
So exactly. So within the CUNY network, countries sort of have to propose a visit. So they have to say what they want to learn. They have to say who's coming. So these are led by the Ministry of Health. It's not always someone at Rose's level of seniority, but they're led by the Ministry of Health. They always include a representative of the national network of people living with HIV. And then the ministry also may bring an implementing partner. Sometimes CDC comes, sometimes USAID comes. It depends on the topic of interest. It's typically a team of between 5 and 8 people, because we don't want a team of 40 people trying to walk into a health clinic. They have very specific learning objectives. So they don't say, I want to see how Malawi's doing it with HIV. They say, to a country, oh, I'm very interested in the way you're designing your community-based model, and even more specifically, how are you getting the data from the community back into the HIV data system? So that's sort of an example. And then they go on the trip. They have an action plan after the trip. Well, we monitor the action plan. So they say, we went to country X, we saw this, and we're going to come back, and here's what we're going to do. And we follow 3, 6, and 12 months to see if they do that. So some examples of things that people are really interested in are, I mentioned an advanced HIV disease model, community-based model. Some countries really were very skeptical about that in the beginning, and seeing it in action made a big difference. The use of community pharmacies has been, or private pharmacies also, has been of interest. Some countries are doing a lot of that, and some countries haven't done that much at all. So those are just some examples. And those trips we found by tracking the action items really have been quite high impact. So one example is there was a visit from Côte d'Ivoire to Zimbabwe to look at advanced HIV disease, because the ministry and the PEPFAR team were interested. After that visit, it wasn't the only thing that caused it, but that visit contributed to a pilot of an advanced HIV disease model at, I think, 35 facilities. That was with CDC funding. That was successful, and then it was further scaled up. So it's seeing your peers in other countries saying, here's how we do it, here's how it works, has been really extremely powerful.
Thank you. So I promised that we're going to come to the audience. And there's a microphone right here and another one here. Please just say who you are, direct your question to any of the panelists, keep your questions short. We only have 5 minutes before the end of the break. And of course, the responses will be short. Any taker? Yes, please.
Oh. Can I go ahead?
Oh, yes, go ahead while we are moving to the, please. Just move the microphone closer to her. Yes, go ahead.
Okay. Thanks. My name is Susan Michael Strasser. I know most of you here. I'm the Senior Director for Human Resources for Health. I've written down what I wanted to say. And thank you all for all of your work and great presentations. I want to say, how do we match the achievements of 95, 95, 95, which have been no less than incredible, having worked at the very beginning of this epidemic in the late 1980s when we had nothing, with protection of the frontline health worker who shoulders the bulk of the day-to-day caregiving work, which has led to this success. The archetype of a rude or scary frontline health worker, a nurse like myself, while based in very real, very terrible experiences that are not what a nurse or a frontline health worker should ever do, is symptomatic of a larger systemic issue. I'm a nurse. I worked as a nurse in Zimbabwe with no gloves, no sharp containers, no doctor, but hundreds and hundreds of patients. And we would do night duty, and the entire hospital, which was a large hospital, had one nurse and one nurse's aide for night duty. It has gotten better in the last 20 years, but those issues still persist. I want to know what we can do to change this substantially. And I know there has been great investment. And I know Dr. Nkengasong is very, very keen on this issue and has had a special working group, which I've been a part of. But I would be remiss not to say something. And I just want to ask all of us, why does this happen and what do we need to do to stop it?
Thank you. I think there was a hand right here. Please go with it. We'll take 3 questions, then we'll come to the panelists to respond to. Please go with.
Hello. Okay, this is on. I'm MM, and I'm a current global health student. So we've discussed at length HIV achievement as well as priority future focus areas. So looking forward, I'd like to know from the panelists, what lessons have you learned recently from COVID regarding its impact on HIV prevention and treatment? And then what would you want to apply in future pandemic preparedness regarding HIV?
Great question. So let's take the 3rd question or comments from here, then we'll turn to the panelists.
Me?
Yes.
Yeah, hi. Rachel Moreski. I teach global health system strengthening in PopFam. So my question is, given the push by the World Bank and USAID and others, both for decoloniality and localization, how do we think about health system strengthening, as we know that countries that had stronger systems, not vertical systems, not even diagonal systems sometimes, did better in COVID, but also that it responded to other things that weren't COVID, where countries didn't have COVID. And so how do we think about the sector-wide approaches and the diagonalization? And ICAP does it incredibly well, but beyond just hypertension and diabetes integrated with TB and HIV, but true system strengthening going forward. Thank you.
Okay, good. So this is open to the panelists. I will ask that you keep your comments short. I'm looking at our timekeeper, and she's like, okay, we are almost at time, 5 minutes. So take it, run with it. There's no specific order. I mean,
See, Rose has notes.
so maybe Angeli, will start with you, and we'll roll down, and any of the questions could be addressed.
Great, thanks. Thanks for the questions, and I'll just maybe reflect on a few, and some of the questions are connected. The question, Adam, related to COVID, and the recent, just the one that just came, Rachel, about health system strengthening. But first, and actually related to the health HRH and healthcare workers. It's all related. So I think one, I just want to say on the question, Susan, about we as a global community, all of us, I think we have to make sure that we are continuing to prioritize, protect, and promote healthcare workers, and including in that community health workers. We also have to make sure that community health workers have a paid salary. I mean, we're still seeing evidence of community health workers that are volunteering to do the work. So we, just as a global community, we have to keep the pressure on. The health system strengthening question, I would just say the systems, the clinical, public health, and community systems that have been strengthened through the HIV response have delivered for other health threats. Those countries, particularly, and Rose talked about this last night, those countries that have strong HIV responses and systems, the laboratories, the surveillance systems, the data systems, the healthcare workers, the supply chain systems, all of that, those systems were used for COVID-19, and we've seen them used for Ebola and H1N1 and SARS and MERS and all the rest. So investing in the vertical systems have actually, like the ambassador said last night, delivered broader returns. The final thing I'll just say is we saw really important things happen during COVID. Policies that we were hoping and working on for years and years and years, like self-testing, that Wafaa mentioned last night, like multi-month dispensing, 6 months supply. We saw in the middle of COVID, we saw those policies by countries just be adopted and implemented like wildfire. That is innovation at its finest, and those policies are what also protected and continue to protect people from HIV. So we saw a lot of exciting things happen during COVID.
Great. Yes. Go for it, Solange.
That was kind of my hand up. Yeah.
Your hand.
Okay. No, it's just because of what Angeli just said. No, I'm not. I don't know. I think, what did you just say? That it's innovation. You said what was innovation?
The self-testing.
The self-testing and like how these things just happen like that.
Policies.
Yeah. Is that innovation? I don't know. I don't think. So the thing I feel like we've learned, agreed, but the thing I think we've learned in COVID from a community perspective is that where there's a will, there's a way. We're still waiting for a cure for HIV. We're still waiting for vaccines to be, pushed. There are certain dynamics in the global system and the geopolitical system that will, when a certain group is affected, there is much more acceleration. And I think we have to call a spade a spade. And so I think that's how we feel from a community perspective. When I think of innovation, I think of, we have all these calls to reimagine the world and what does transformative change look like. I think we should have been giving out the 6-month dispensing a long time ago. I don't know if that's necessarily what I would say is innovation, not to disagree with you, but just to think, can we push ourselves as a community further, as a HIV response further? And I think that where we're stuck and where we get hesitant and we get pushed back is when you start to innovate with community-led interventions. And I think that is, for example, community-led monitoring doesn't belong to HIV. It doesn't belong to any particular sector. It belongs to communities elevating the problems that they have and saying, can we track it for a solution? So we're currently working on CLM for water, for access to clean water and getting those things funneling back. And I'm trying to talk about exactly what you said, Angeli, and what others have said around HIV being the leader and really infusing within the system where others find it struggle for the community participatory models. How can communities add to this and being able to track that along? I think the question on the human resources for health is a very complex one, and I think all parts need to come together. But I think what we need to make sure is that we do not just look for financial systems, like more money. I don't think injecting more money is only the solution. It's a very complex issue. Thanks.
So, Rose, you have the last word in 30 seconds.
I think my comment relates to the question that what can be done to change the issue of protection of health workers. I think for the case of Malawi, one reform area is health workforce optimization. And on that, we are looking at reviewing the scope. I think HIV and even COVID and these other diseases have brought in a lot of changes in terms of the scope of work for the frontline health workers. And that should be aligned with the staff establishments. So looking at the scope and then the numbers, both at facility level and even community level, so that we reduce the pressure that these health workers may have. But also we have developed a care and carer policy, care of carer policy. I think the coming in of, I think HIV, we all know we lost a lot of workers. COVID also came in, and they need to protect health workers and have policies that can be implemented or functional. I think that's something that we have done. Whether the policy is going to be implemented fully and funded, that is something else, but that is the case for Malawi as of now. Thank you.
Wonderful. I think we will bring this session to an end. Thank you so much for the very interactive.
Thank you very much, Ambassador Nkangosang, and all of the panelists and our keynote speaker for really a terrific session. Thank you, and thanks for your engagement as well in the conversation. We're going to move on now to the second session, and our second session is entitled Meeting Current and Future Global Health Challenges. And we're going to start the session by inviting Ambassador John Nkangosang to give us a keynote address to start it off. Welcome.
Again, thank you, Wafaa and ICAP, for inviting me to be part of this celebration, 20th anniversary. I don't think anyone has congratulated you this morning. Let me start off by congratulating ICAP for, no, I think the Dean did, for your 20th anniversary. So I was charged to share some reflections on global health at the Crossroads. We've heard a lot about HIV, and I will touch on that somehow very briefly, but really focus on just sharing my reflections after about my 35 years in global health and public health. So, as Jessica said earlier, I mean, the approach I took was to consider that it's a mixed audience. It's like when you're writing that perspective for Nature or Science, you say, write to the general audience so that you capture those who are beginners in global health, the intermediate, and the more advanced groups. So I promise that some of my comments will be intentionally controversial to provoke a reaction. I also take advantage that I'm in an academic institution where you can think freely and you are not constrained with the bureaucracy of being in government where you say that. So the comments that I make here, my comments, my views, and do not reflect the views of the State Department. So a couple of things I would do just to arrive at that dialogue of is global health at a crossroad? I would examine the evolution of global health and some definitions. I'll also look at global health threats at a crisis and the governance that we have, what we have seen in global health. So first of all, some definitions towards a common definition. I think if we have better definitions of what global health is, then we know what we are trying to address. Okay? The question I always ask myself is, what is the question? What is the problem we want to solve? And about 2009, a couple of very high-level, iconic public health experts came together and wrote a perspective or a viewpoint in the Lancet, which was really, really thought-provoking. And it says, and I invite you to read that, it says, global health is fashionable. That was 2009. It is still fashionable today. And it provokes a great deal of media, student, and faculty interest. and has driven the establishment or restructuring of several academic programs and supported by governments as a crucial component of foreign policy and has become a major philanthropic target. A lot was said in that paper. And they go further and say this, which is really an interesting, thought-provoking piece. It says, when it is, the definition varies greatly and is often little more than a rephrasing of common definitions of public health or politically correct updating of international health. So let's start with what some of the very key, the evolution. When I was researching this topic, and over the years when I've given thoughts to global health, it has occurred to me that the period you are living in determines how you see, I'll call it planetary health, because my next slide would discuss tropical medicine, international health, and global health, so planetary health. When the British pathologist Harold Scott was faced with planetary health at that time, he defined tropical medicine in the context of what he was living at that time, what the world was living at that time, and what they saw as the issues that they had to address at that time. I put this text here so that, it's highly recognized, and he was the president of the Royal Society of Tropical Medicine. And I say this just to create an awareness that as we move forward and try to define global health, if we conquer the spirit of what I call the spirit of the moment and project further past our own period, it could help us arrive at a good place with a definition of what is the problem we want to solve and what is global health. So read what he says here. He says, we can then trace how improvements have been brought about, usually first with a view to safeguarding the health of officials and European traders, and later undertaking also the treatment of natives, by which two purposes could be simultaneously achieved or accomplished: benefit to the health and well-being of the native, and further protection of the white man from native-borne infections, end of quote. That was the definition of tropical medicine. In 1948, the WHO was created. And the WHO, in that creation, I went back to, as I was preparing this reflection, went back to the constitution of WHO to look at what our governor, the governance of the World Health is with WHO, why were they created and what were they supposed to do? A series of things occurred to me under Article 2, and Article 1, first of all, talks about attainment of all people of the highest possible level of health, of all people of the highest level of health. But Article 2 goes further, and it talks about some functions, a series of functions, but those that drew my attention included to act as the directing and co-directing authority on international health, and to promote maternal, child health, welfare, and to foster ability to live harmoniously in a changing total environment, and to foster activities in the field of mental health, especially affecting the harmony of human relations. Very important. At that time, it was international health in the 1940s. Not even the word global health was not used. So how have we evolved? I just talked about tropical medicine, which in the 19th century and early 20th century was what it was at that time, preserving the health of European colonial rulers, protecting the health consequences related to tropical diseases. I and others attended tropical institutes, attended the Institute of Tropical Medicine in Belgium. Several others here, including my wife, attends the London School of Tropical Medicine. So all those structures serve the purpose and continue to serve the purpose now. But it has evolved. And in the second half of the 20th century, international health emerged and focused on prevention, measures to treating infectious diseases, and those that are listed here. And the last 2 decades have now witnessed a transition to global health with a broader agenda of what global health is. And I think when I sit back and look at a celebration of ICAP's 20th anniversary, I look at a collective of other institutions and systems that have emerged over the last about 20 years or 25 years. The Gates Foundation, PEPFAR, Global Fund, Gavi, FINE, and others, CEPI, have all emerged over the last close to 25 years. So where does that put us? I mean, this is the cartoon that I thought will reflect the moment, which is suddenly the person driving that black car gets to a crossroads. So my goodness, I'm at a crossroads. Now, where do I go? And this is global health. And there are three things that choices you have. Either the road, you keep doing the same thing and you go nowhere, or you go anywhere, or you go somewhere. That is the choices we have, or the choice we have in front of us as we define or seek to define global health. So what is the crossroad we find ourselves in? So very complex. I mean, for global health, it's not for the faint-hearted, and the issues that we are dealing with have become very, very complex over the years. And there are several here which I will not go into details, but I've highlighted those in red that I would like to expand a little bit on because of the interest of time. And that includes global health governance challenges, and I call that the crossroad component of that. I will now look at the second red part, which is global disease threats and inequities, which is the HIVs, the TBs, the antimicrobial resistance, emerging infections that we are dealing with, and global economy and the financing. The administration, President Biden, has called this moment an inflection moment, which is the challenges that we are seeing in global health, especially financial challenges, will continue to be driven by factors that are outside of global health, including climate change, the economy, debt repayment. In some countries, in developing countries, about 90% of GDP is being used in reservicing debts, and that affects global health at any rate. But I'll focus on those three. So let me start with global health threats as a crisis. Why is it a crisis we are dealing with? Because if we have to deal with all the issues in the manner we've dealt with HIV/AIDS, they are complex in nature, and it lends itself quickly to a crisis. These are some of the factors that we are faced with today. The population, when the likes of WHO and others were created, or even the UN was created, the population of the world was at a very different place. This graph shows you the population explosion, especially in Africa. If you look at the red line there in Africa, by the year 2050, 1 out of 4 human beings on Earth will be an African. Then you look at what that means in terms of urbanization and increased movement of people. At the far right-hand side there is a snapshot of what the skies look like in July. Okay, or June or July, in how much we move, and conflicts, climate change that we've touched on, and I've touched on some of this very shortly. That's how climate change and disruption of ecosystem is impacting all of us. And because of that, diseases are emerging more frequently. I did a simple exercise by mapping out the occurrence of Ebola outbreak in DRC over the years in my previous job as the director of the Africa Centers for Disease Control. And I said in 1976, when Professor Muyembe and Peter Piot identified Ebola, the next episode was in 1995. So that was a period of about 19 years. Then subsequently, the next episode was in 2007, 12 years, and then 7 years, 3 years, and now every year. And in my previous job, I used to go to the Congo almost twice a year because of an Ebola outbreak, just because of what I showed in the previous slide, interruption in the ecosystem, the pressure for food security or insecurity. People are moving into those areas to get a source of protein, and because of that, there's exposure. Then in January or December 2019, COVID hit, and look at how quickly, within 2 months, what COVID did. It moved from 4 countries on January 20th to 28 countries affected in February 15, 66 countries in March the 1st, and 165 countries in just 2 months. That is what we saw. Okay, so it's not just a virus spreading, but it's meaning lives. These are our loved ones. And this picture, before 2019, one would have imagined that we were in 2018 because of the Spanish flu. But these are pictures that we live with and we live through. If we leave that for 1 second and look at mental health, because WHO framing discuss mental health, which we have argued that neglected for so long. WHO tells us that in 2020, about 264 million people suffered from depression worldwide. 264 million people, but yet it is not elevated and discussed the way it should be discussed. If we in this room discussing HIV said, in 2020, 264 million people were suffering from HIV, I don't know how we will react to that, but it's a question for reflection. Then you look at maternal child mortality. Yes, declines we've seen, about 34% since 2000 to 2020, but I ask that you look at Africa, and every yellow, orange, and light orange color represents high levels of maternal mortality. But look at that, if you sum all of that, it tells you that we've not made progress in the way that we should make, especially in Africa. So that is an area that global health is still struggling. But if you look at the United States, we've heard in the media just recently, that how much we in the United States are struggling with maternal mortality there. The graph you see here tells the story that there's a significant increase with respect to the previous years. If you look at just 40 and above, for the 2 years, 2020 and 2021, it doesn't tell the story that we are winning there. So it's truly global. It's not just something we are doing in developing countries or in Africa, but it's something that is affecting us here as well. Just recently, we're all alarmed to see life expectancy in the United States dropping. And this slide shows you a grouping of 11 mainly industrialized countries, and where you have the orange color is the United States in terms of life expectancy. Then if you break that down further, you begin to look at life expectancy by race. You clearly see Native Americans, Alaska Natives, Blacks, at the bottom there, really decreasing life expectancies. Then you turn your attention to another area of global health, which is vaccination coverage there. And this is a recent study just published by a group in Africa, very clearly showing you the gaps. The red is what we should be looking at, mainly the gaps that we still have. And even the blue colors, those that have received incomplete vaccinations, and the reds are those that truly have just not been vaccinated. If you look at Nigeria, Ethiopia, in Africa, I always said in my previous job at the Africa CDC, there were 5 countries that I watched very closely. It was Nigeria with 230 million, Ethiopia, Egypt, DRC. If you combine those countries, they give you almost half of the population of the continent. So you don't want so many reds in those countries. I mean, if you have so many reds in Ethiopia, Nigeria, Egypt, or Egypt is not here, but you get into trouble because that is a large number of people that you're dealing with on the continent. But clearly, you see that vaccination coverage, we've made progress, but it's still a long way to go. Then we look at the United States here, and studies from the CDC are showing that we have declining rates of vaccination in our kindergartens right here in the United States. So it's not just an issue affecting others in Africa or developing countries, but it's also affecting us here as well. Then we turn our attention to non-communicable diseases and look at hypertension. And the graph you see here on your right-hand side shows you the leading cause of preventable deaths in the world, and high blood pressure accounts for about 10.7 million. And if you compare that to, without minimizing it, HIV, TB, and malaria, it gives you a perspective of what we are dealing with. So what is even more important and concerning in terms of global health is the level of undiagnosed hypertension. On the right-hand side here, my right-hand side, shows you in red the level of undiagnosed hypertension. And the orange color shows you the people that are actually are under treatment, but they are not responding to treatment. So what you're essentially looking at is the green color, which is the controlled hypertension. The treated but not controlled, the diagnosed but not treated, and undiagnosed really constitute most of the burden we are dealing with. But that is number one killer, and it's not getting the attention that we should have. So if I'm a young person, I would ask the question, what has global health actually achieved? What is it there that we can show in global health? And there are some success stories, and just wanted to share some, not many. Smallpox eradication is a success story that we celebrate all the time. Childhood immunization, we made a lot of progress, even though we have been challenged recently, where the rates moved from 20% to 84% in 6 years between 1984 and 1990. Polio reduction from about 350,000 cases to 700 cases in less than 20 years. Guinea worm and onchocerciasis, those are all successes that we've seen in global health. Perhaps in the last 20 years, the greatest success we have seen is in the HIV. And we've seen this slide over and over during the last session. I just wanted to show this slide to make the case that that's what success looks like. Yes, we are not at the finish line, but it truly shows that what is possible. And on that, I would like to share a few more results that we've seen in HIV, especially from the PEPFAR lens, which Jessica mentioned, 25 million lives saved, 5.5 million baby born free of HIV/AIDS. And if you look at the number of the reduction in terms of AIDS-related deaths, about 68%, and 42% new infections. That is what success looks like in global health. But when you look at this, I think I'd like to implore you all to think about what are the lessons, what are some of the lessons that HIV/AIDS response can teach us as we think through global health going forward. In my view, there are at least 4 of them. One is sustained engagement. Sustained engagement. We've only gotten here because the last 20 years or so with Global Fund, PEPFAR, and domestic resources, we're determined to engage and stay engaged for 20 years. It wasn't touch and go. We didn't come in with resources and then did that for 2 years and left. We did it consistently for a long period of time. Second is the ability to set targets. The ability to set targets and use the targets. That's why UNAIDS is so important. I continue to call it a Northern Star that will tell us where we have to be. The 90-90-90 by 2020 or the 95-95-95 by 2025. We have to have that. Thirdly is the use of data. I mean, we just heard in the last session how we can use data at granular level in order to drive outcomes. And lastly is what I call a steady leadership. The systems that we put in place in global health or in public health are very fragile. You have to have continuous leadership, engaged leadership. I say that because I use UNAIDS as a Northern Star, but UNAIDS started from GPA, the Global Program on AIDS, which I'm really honored that Michael is here, Merson is here, who is one of those who were the founders of the Global Program on AIDS that subsequently gave birth to UNAIDS. That is what I call steady leadership. They have all done their piece and moved forward. Angeli and Winnie are doing their piece today, but that is the kind of leadership that will be required for us to solve the complex problems that we are dealing with in global health. So if you ask me what are those key lessons that we must apply in global health going forward, I think those are those, including the power of partnership that we touched on yesterday. If we do that, then the outcome of what we have is not just impacting the disease in question, but you have a spin-over effects. This is what we are seeing in PEPFAR, that because we are addressing the HIV/AIDS using those lessons that I just highlighted, there are other outcomes that we are seeing. GDP in countries that PEPFAR has invested has increased by 2.1 percentage point, about 35% childhood immunization. The mortality rates have been achieved. Less than about 10% immunization rates have increased, especially in countries that are struggling with that. So that is what we see. I'd like you to look at a recognition of that and say, this is what we see this is what success looks like. The former president of Botswana wrote this piece in The Hill with former Secretary Thomas Thompson, and the title is How PEPFAR Helped to Save Botswana from Extinction. That is the power of what it means to be focused and to address a global health issue. So let me use my remaining 5 minutes to look at where we are with governance of this, the crossroads, and start with some definitions. Elinor and others have helped us provide some context with definitions. First of all, she defines global health governance, and then subsequently flipped it and look at global governance for health and governance for global health. They all sound, they're different variants, but they have very different meanings. The importance of this, if I was a young public health or global health aspiring person, is to take note of this because they have implications. They all intersect with each other, and they have implications because the world has changed. Over the last 25 years or so, about 175 initiatives, funds, agencies, and donors have emerged. I mentioned some just very quickly. And because of this, there's complexities in coordinating global health. Everybody convinced. I was at a meeting the other day, and I saw 3 individuals, and I said, describe for me how you've spent your last 2 months. And one of them said, I was at the UN General Assembly, attending some global health meetings convening in September. The week after, I was in Senegal and attended the Grand Challenge meeting with the Gates Foundation, no issues with that. And at the end of the week, I was in Berlin attending the World Health Summit, and then left from there to Chicago to attend the tropical medicine, and then went to the infectious disease. That is how that person had spent the last 5 weeks. That is the challenges we are dealing with all of this there. The question we have is how do we change these challenges and transform these challenges into things that can enable us to solve global health problems, including financing. We talked about sustaining the responses there, and I just want to use this slide to make one point that if we have to win the battle against global health going forward, it is domestic financing. This slide shows you 3 things. 1, the blue is out of pocket. A lot of health financing in developing countries is out of pocket. Then the orange colors are government expenditures, and then international expenditure is the gray colors there. So at times we look at the funding that, say, PEPFAR puts into a country or a global fund, but we ignore that most of that, the funding that will make a difference is domestic financing. We really have to be very intentional. As Jessica said, the US is one of the largest global health funder, but that funding is mainly the HIV, that is the blue part of it. But HIV funding for PEPFAR has been flat for the past close to 10 years. And the red piece you see, the slide you see there is global health security. And you can see how little it has changed from 2011 to 2021. Just not much in that space. So domestic financing is so important. Then we look at the new instruments that are emerging to fill this space, the pandemic fund. The pandemic fund was launched with the goal, aspirational goal, to get to $10 billion a year for the next 5 years. Today, we're at 1.9 billion pledge, 1.9 billion pledge, so short of about 8 billion to get there. It tells you the financial space, how tight that space is, and what we must do to look to be creative there. Somebody said in the panel, I think it was Solange said, we have to do more with less. If we have to do more with less in global health, as I conclude, we have to look at how we diagonalize global health, which is to say that what are the things that are cross-cutting? And rather move away from the discussion that looks like vertical programs are not good for us. Vertical programs have delivered results. They have helped strengthen systems. But we should be looking at very intentionally how we coordinate these programs that have emerged over the last 20 years. And can we intentionally allocate resources in strengthening horizontal systems, not creating a false argument between vertical systems and horizontal systems? I truly call them false arguments because we've seen the power of what vertical systems have done. I offer that slide to shape our thinking going forward. Secondly is the political. We cannot ignore politics. Again, I show this slide over and over. It's a book written by Peter Piot. I understand you'll be here this week. But what I love in here is that it says that science does little good when it operates independent of politics and economics. And politics is worthless if it rejects scientific evidence. We've seen the struggle we're going through even in the PEPFAR reauthorization. That is politics, right? So we have to continue to, if global health has to be prominent and be protected and advanced, we also have to think of the politics of what we do as health experts to engage in that space so that we can actually get to that crossroad. So to conclude, where do we go from here? If I were this driver, where do I go from here? So I would argue that the same concepts we have used in advancing global health security, which is the spirit of cooperation, better coordination, collaboration, and communication will prevail if we have to make sense with global health and advance it and find a way in the crossroad. I call it, or what the Secretary Blinken has characterized as diplomacy variable geometry, which is essentially saying we identify what the problem is, find the right partners, both in shape and size, and address the problem in a sustained manner. If the problem is dealing with hypertension, I mean, who are those partners that are ready to stay engaged, committed for a long time, so that we do not go in just to do what I call the fix, the touch and go solution. They do not work in global health. Lastly, we have to make global health truly global. This is an excellent paper that was written by a combination of experts from University of California in Cape Town. And they said this, they say, in the name of global health, the trend of academic institutions. And I bring you this as an ask that you see what they're saying here. They're essentially saying, if global health has to be global, where are the global health institutions in academia in developing countries? You hardly have I seen in Uganda or Tanzania an Institute of Global Health in Tanzania or Kenya. Okay, these are concepts that have emerged very rapidly in developed world. So we have to intentionally engage the developing countries so that they have the same understanding of what we are trying to do. If we do that, then we begin to address this inverse care law, which was published in the Lancet in 1971, which talks about the inequities that exist, that resources are always available where the needs are less versus where they should be. I think we should take that global health concept right to the core of where it should be. So I thank you. I just wanted to be sure that we have an openness of mind and do not go back and have an understanding of global health in the spirit of what Harrods and others thought of it in the early 90s. Thank you for the opportunity.
Thank you very much, Ambassador Nkangazang, for this really very important talk. You've put into perspective several very important concepts and have really brought us back to where we started from, where we're at, but also, most importantly, where do we need to get to, which I think is the purpose of our coming together today. So let's move on now, and I'm going to invite our next panelists who are going to come down here and join us for the next conversation. It gives me great pleasure to welcome Terry McGovern. And Terry is a Senior Associate Dean at the City University of New York in the School of Public Health and Public Policy. Please, welcome. Next, I'd like to invite Jeff Shaman. Oh, there he is. Great. Welcome, Jeff. Jeff Shaman, who is the Interim Dean of the Columbia University Climate School. Welcome. Next, I'm going to invite Ashwin Basan, who is the Commissioner of Health for New York City Department of Health and Mental Hygiene. Welcome, Ashwin. And next, I'd like to invite Mesfin Teklu Tesema. Welcome. And he is a Senior Director, the head of the Health Unit at the International Rescue Committee. Welcome, Mesfin. And last but not least, I'd like to invite Ruben Sahabo, who's the Country Director for ICAP in Eswatini. Welcome, Ruben. Great. Perfect. And we will do exactly what we did in the previous session. We'll start with the lightning round of brief presentations by our panelists, and then we'll start a conversation and then take your questions. So, Terry, please.
Do we have can someone advance the slide?
Oh.
Okay. I needed to remove that picture. Hi, everyone. It is really an honor to be here. I started working on HIV, like so many of us, in 1987, and I see many faces that I have known since that time. So it's really an honor and humbling to be amongst all of you. So I'm going to talk about adolescent girls and young women and HIV and some other things, of course. So, we know fewer adolescent girls and young women, 15 to 24, are acquiring HIV than a decade ago, but many of them still face HIV risks. There's been, approximately 210,000 acquired HIV in 2022. We know that long-standing gender inequalities, discrimination, poverty deny many women and adolescent girls economic autonomy, deprive them of control over their sexual lives, and expose them to constant risk of emotional and bodily harm. All these factors obviously increase risk for HIV, particularly in sub-Saharan Africa, where HIV prevalence among adolescent girls and young women is more than 3 times higher than among their male counterparts. So we obviously need programs to improve delivery of HIV prevention testing and treatment services to this population. I would also add on, we have long-standing issues with discriminatory law, sometimes customary and religious law, requiring third-party consent. We have politicization of women and girls' health, like things like the global gag rule. We have confusion about civil law versus discriminatory religious law in many instances, and lots and lots of ways that countries get out of their commitments under international law. So the granularity, I think, is where the answers are. We know that often only married girls get access to treatment. We know age of marriage continues to be an issue, and many obstacles to youth-friendly services. There's also an issue of data, poor data. Disaggregation is still limited in many vital statistics systems, and these are extremely weak. And obviously, survey-based indicators are very, very important when we're looking to drill down on what's actually happening. And of course, that age-old issue of sexuality education is still lacking. That being said, we have some progress. Globally, the rate of new infections in adolescent girls, young women dropped by 50% from 2010 to 2022. HIV incident rates vary, and are highest in sub-Saharan Africa, where the youth population is projected to increase by 40% over the next decade. So this is worrisome. There's growing evidence of what works to address biological, behavioral, structural factors that contribute to vulnerability for these young women, girls. Direct interventions include newer testing approaches, self-testing, index testing, condom, obviously all the things you've heard, STI services, integration of services, indirect interventions, school-based prevention campaigns, programs to change gender and social norms and prevent GBV. A note on that. Often we only see sexual violence being addressed because norms are so strong in support of interpersonal violence. This obviously makes it very difficult for young people to negotiate safe sex, etc. We need all kinds of economic empowerment interventions, and of course, as the ambassador mentioned, we need mental health services. We also need incentives to comply with civil or international law to overcome some of those discriminatory laws. Over the past 10 years, DREAMS, has a public-private partnership, has rolled out in 16 countries, and has provided a multi-layered package of interventions. But this is more difficult in our current context, right? War and conflict, climate-related shocks and displacement, economic downturns. So I want to talk about, at this time of change, how are we addressing these problems? Women and girls are disproportionately vulnerable to HIV infection during and after armed conflict, during displacement, and in times of economic stress. There is, of course, as we all know, rape, transactional sex, a lack of access to HIV prevention and treatment. We have data in sub-Saharan Africa, HIV prevalence increased by 2% following an armed conflict between 1990 and 2012. Less than 20% of people in war or conflict regions receive ART. In Lesotho, droughts are reported to be associated with a 5-fold increase in transactional sex and 3-fold increase in rape among women and girls. And of course, the risk of maternal mortality is 2 times as high for girls or pregnant people, 15 to 19, and 5 times as high for 10 to 14-year-olds compared with 20 to 29. So we've got to actually drill down on what are the obstacles for girls, for young women in humanitarian, in climate change, and finally address these long-standing issues. And of course, I'll end with political will and the politicization of healthcare of women and girls in the sexual and reproductive health range of services. That has got to stop. So I'll end there.
Thank you.
Thank you, Wafaa. It is indeed a pleasure to be here as you celebrate this milestone for ICAP. Congratulations to you and everyone on your team. I was asked to talk a little bit about climate and just talk about some of the health implications of that. And so in just lightning style, they're myriad. There are a lot of them. Here's a nice little list of some of the outcomes or impacts that we can see associated with climate variability, changing climate, global warming, and increases of temperatures, and changes to the hydrologic cycle. Obviously, this includes death, straight up mortality, shifting disease patterns, both chronic and infectious, increased mental stress, under and malnutrition, adverse child development. The list goes on. I don't need to read it all, but there's a breakdown of it where you look at some of these impacts, and some of them are going to look very direct and maybe a little bit intuitively obvious, and others are really thinking about the climate system as a stressor that actually multiplies or exacerbates existing problems, inequalities, that compounds with other stressors that may have to do with food insecurity, water insecurity, conflict, and economic downturns. And it's this confluence where we see some of the most devastating impacts and things that are very difficult to get our heads around. I do think that there has been some progress in climate and health, and I'll get back to why I said some in a moment. We have some increased understanding of what some of those health impacts on climate change are, what the effects of increased temperatures are on renal disease, on morbidity and mortality generally, what are the strategies for coping with it as we look at temperatures that are totally inhospitable. One of my most depressing statistics of this year is that in southwest Iran in July, the Persian Gulf Airport recorded a heat index, which is a measure of combined temperature and humidity, of 66.7 degrees Celsius, which is really unheard of. That's 152 degrees Fahrenheit for those of you who need it. Those kinds of conditions are not tolerable for the human beast. And so that's something that we're really going to have to contend with as we see more and more these kinds of extreme events, routine excursions of temperatures above 50 degrees Celsius in places like India and through the Middle East. We've also seen, as some of the achievements, greater benefits for basic research. That includes from the NIH at long last here in the United States. Debate on the veracity of climate change has become much more limited. Corporate and municipal investment in climate and health is rising. In some sense, that is the real motivator, one might argue, for getting things moving. And we're starting to entrain laboratory studies, which I think is very important, that we actually get this into a wet lab setting and have bench studies of what are some of the consequences associated with our changing environment in a more physiological perspective. Also, recognition, as I said, of climate as one of many stressors that we're confronted with. I think priorities and the ways forward is that we need to elevate the recognition of climate and health more broadly, and we have to get beyond our own cognitive dissonance about it. And by that, I mean, one of the biggest impediments that we have is, I can talk about climate and change and health all the time. I do it all the time. I talk about climate change generally, but it's such a large, enormous problem, it's very difficult to get our heads around it. We don't even know within the scientific community very often, how do we actually fund this? What should we be working on? What are the bite-sized problems that we can start to use to address the issues that we're seeing, particularly when we're seeing these complex interactions and effects? How do we get away from a 40,000 view into something that's a little more maybe practical and on the, in the local communities, as it were? So that's something that we really need to do. We want to also, of course, keep and improve health while the climate is changing. And that means a hardening of our systems and a recognition that things are going to change and what that means for how we deliver healthcare and how we think about public health broadly. We need further engagement of the clinical and public health sectors in that, and education and re-education is a very important facet of that. And some of the topics of concern there you can see listed. And we have a little schematic here, and that's something that we put together here at Columbia University, together with Wafaa and Dean Freed, is something that we thought about, thinking about how do we model it? What are the human population studies? What are the cellular molecular studies? And how does that unite in a complex system dynamics that we actually have to think about? So I'm going to stop there, and I will pass it on.
Thank you.
Hi, everyone. Great to be here. I was asked to speak about the local perspective. We're here in New York. ICAP works in New York. Congratulations, Wafaa. I met Wafaa, I want to say, almost 20 years ago in Ethiopia. That's the first time I met you, working on HIV, which is where I started my career. So it's so incredible to see the impact of ICAP over the last 2 decades. And really, as we said last night, long may it continue. But I was here to talk a little bit about some of the challenges we're facing here in New York City around public health preparedness in particular, after the lessons of COVID-19 and otherwise. I think it's important to see this in context of what has been written about and talked about during the pandemic, which is cycles of feast and famine or panic and neglect. But it's important to have an analogy to compare it to, and that the best one I can think of is the military, right? In the military, you've got a national reserve, you've got a guard, you've got a group of people who are training all the time, keeping themselves fit and ready for action. There's obligations. They get paid to do so, right? They get benefits. And then when there's crisis, they leap into action. We have nothing like that in public health. And so when we see public health challenges come our way, often much more quickly and in unexpected ways, like we saw with SARS-CoV-2, what we end up doing is pulling resources and assets from core functions that you all expect as taxpayers, right? Your tax dollars, I assume most of you live in New York, pay for my salary and that of all of the Department of Health and the public health system in New York City. And yet you expect us to do basic things like inspect restaurants and provide school nurses and make sure that our water quality is of a certain, and air quality is of a certain level. And of course, provide frontline sexual health services and so on and so forth. And all of that in a crisis gets pulled into something else, into some other form. So it is important that we start to challenge these assumptions of how we set ourselves up for the future, because that model of kind of activation, we call it in public health preparedness terminology, is based on crises that are usually time limited in scope, somewhat understandable in terms of their dynamics, with clear medical countermeasures that we can deploy. And as we saw with COVID-19, while we ended up figuring all of that out, we weren't necessarily as prepared as we would have liked to have been. So 2 infectious diseases in particular have really strained our system. Obviously, COVID-19, unprecedented in its speed, its scope, its size, and duration, certainly in the modern era. More than 60% of our staff, just our staff here at the health department, were drawn away from their daily work and quote unquote activated. So that's a lot of work that didn't get done also in its wake. That is to say nothing of the 40,000 healthcare workers that we indirectly oversee in our public hospital system, who then were drawn singularly to these issues. So just keeping that in mind of what we're drawing upon to activate and to respond to unprecedented crises. Strain, stress, not just at the human level, but at the systems level. Staffing, procurement, deployment of resources in our supply chains. Every single piece of getting things done in public health was put not only under a microscope, but under incredible amounts of strain. And then Mpox, a new old visitor, coming to our shores in a new way, and frankly, wasn't as great in size, wasn't as great in scope, but was coming on the heels of the worst of this highly transmissible, highly infectious, highly lethal SARS-CoV-2 pandemic. And I would say that, frankly, some of our radar was scrambled. Some of our radar was scrambled at the beginning of this response. Not to mention the fact that already marginalized people were disproportionately impacted. And frankly, while Mpox didn't have significant mortality, the morbidity, the pain associated was non-trivial, really non-trivial, and something that, frankly, public health, I think, failed to capture early on its severity and really lift up those messages. But leaving aside our readiness, we also had, at a national level, we had limited vaccine supply. We thought we were ready for this, right? We had a stockpile of vaccine, we had a test in hand, but we couldn't turn the gears on fast enough, right? We couldn't turn the gears on fast enough. The reasons why? Well, some of it was feeling a little stunned, frankly. I don't think it's not that we didn't know the answer. It's that we didn't know how to turn on our public health apparatus quickly enough. We didn't know how to get New York City, which was the epicenter of the outbreak, of the epidemic, the resources it needed early enough. We obviously had a lot of treatment challenges related to investigational treatments, and of course, further strain on health workers that felt like they needed to now all of a sudden start getting their heads around this new pathogen while they're still dealing with new variants of COVID-19. So it was non-trivial, the effect of Mpox, but we did certainly learn a lot. So as a result of these challenges, and certainly in the approaching 2 years that I've been commissioner, we've focused on this notion of response readiness. What does it mean to have a public health department and a public health system that's front-footed? What does it mean to have a group of people within the health department, within the city, that's ready to respond? It'll never be the size of a military apparatus, but it can be something that can move much more quickly and proactively than we've seen in more recent responses. As well, how do we build in principles like equity, like trust, and operational capacity to support the flexible scalability and downscaling of responses? By operational capacity, what do we mean? We mean effectively managing the day-to-day emergency response through planning, training, interagency coordination, and the availability of even the financial mechanisms to get money out the door to buy the commodities and hire the people to do the thing. Building trust with public and other types of organizations, other government agencies, with communities by communicating transparently, clearly, and not just acknowledging past errors, but also acknowledging what we know and what we don't know at the moment. One of the things that we've been trying to inculcate at the health department is the ability to say, this is what we know today, this is what you should do today, this could change tomorrow. That does not undermine us. In fact, that's what the public wants to hear. They want to hear what we know today. And if we think it might change tomorrow, that's okay, because science changes, understanding changes, data changes, information changes. Working towards health and racial equity from the beginning, what does that mean? That means disproportionately planning and investing, prepositioning assets, relationships, contracts in communities that we know will be hardest hit. We know that will be hardest hit. In this first phase of developing a response-ready plan for the agency, over 1,000 individuals were interviewed, contributed from all walks of city, non-city actors to create a blueprint for how this city can move forward. We'll be releasing that very soon. Data. It doesn't work unless we have a better data system, a faster data system, one that's able to provide actionable information. We're awash in data, we're not awash in understanding. And that means that the city really needs to build the common data infrastructure to take that morass of data and develop actionable insights. So we launched a Center for Population Health Data Science this past October. Some of it is leveraged by CDC Data Modernization Initiative funding, but the central tenet of this center is how to take myriad data, administrative data, clinical data, social services data, and bring it into insight that we can use to drive resources into the strategies that work and into the communities that need it the most. For those of you who have been around global health a long time, and certainly there's folks at Columbia who've led on this, the best thing I can think of as an analogy is DSS, demographic surveillance sites. How many of you know what that is? Yeah, a few. What does it mean? It means the end-to-end control of data in a region to be able to have actionable insight. That means healthcare data, that means vital statistics data, that means household survey data, and in some cases, social services data, supply chain data, and then of course, vertical program data like EPI, expanded program and immunization, and otherwise. That's what we're trying to build here in New York City. Some of the core skills and tools that we're building out, data visualization and communication, forecasting and modeling. During the pandemic, we relied on Jeff and others like his group to do forecasting and modeling for COVID. That could be a great partnership to build and scale, but we also have to build capacity in-house to do this for the public. Matching and analysis of different data streams, data governance, privacy, and interoperability, and of course, leveraging AI in support of the recent citywide AI strategy released by our Office of Technology and Innovation. Lastly, we need to pay for all of this. We need to figure out a way to finance public health emergency preparedness despite the loss of federal dollars. We've talked a lot about what we built during COVID. All of that's going away. We are facing massive fiscal cliffs for things that you've come to expect, like wastewater surveillance, congregate settings investigations, community health worker programs, data visualization capacity, modeling. All of this is going away. Mobile clinic infrastructure, things that now you want the next time there's a pathogen that comes our way, and we're not just going to be ready to scale it. So we need to think carefully about what we're paying for. We're looking at that in-house in ways we can realign our budgets to support this work permanently, but we are going to need help from the federal government, and it's it's very challenging when we hear about the CDC's budget being cut. Lastly, collaboration, and it's not on the slide, but the fact that we have got something like the PRI, the Pandemic Response Institute, housed at ICAP and at Columbia, is a wonderful partner to have for the next time we're faced with such a challenge. We can't do this alone. Government can only really provide the architecture and the framework. It was going to require public, private, nonprofit, philanthropic sectors, community organizations to step into the fray, just as we did during COVID. But we need more guidance, more support, and more resources to do it more effectively. So thanks.
Thank you very much. And I encourage, as Ambassador said, to keep an eye on Mariah because she holds up the time signals. Okay, thank you. Go ahead, Mesfin. Yeah.
Moving the slide. Okay, thanks, Wafaa, and thanks for having me, and also congratulations for this milestone. So I was asked to talk about, forced displacement and migration, which is a key global health challenge. I think when you think of global health at a crossroad, I think, our story will not be complete if you don't talk about the people who are at the brunt of, receiving this threat of whether disease or any kind of, health risk. So just a couple of, background, I think just to set some of the statistics out there. We are at a situation where we are experiencing a record number of forcibly displaced people, I think, which is, the recent UNHCR report showing 140 million, just as of September 2023. This is, growing, and especially the last decade, I think this number is exponentially growing. And of course, majority of them are living as internally displaced, mainly driven by conflicts, of course, and new and unresolved conflict. And climate change is also making it even worse. So I think it's important also to recognize that, many of them, they do live in low and middle income countries. So despite the fact that, the media and with the news cycle, what you see is that the refugee crisis in high income countries, which is, a real challenge, and I think it has to be addressed in its own right. But I think, most low-income, middle-income countries are actually handling the majority, nearly 85%. And, they also end up settling in some of those neighboring countries. And I think that shows, the global nature and how the distribution of responsibility for, especially those who have the limited resource to care for their own population, as well as displaced. The other thing is, protracted displacement is now the norm. Most refugees, they live more than 2 decades. And to think that, refugees like, an acute crisis, which is going to go away with humanitarian response, is no longer the norm. So I think we need to think of, as we are thinking of, economic development and, national integration and what's needed, for countries. So again, looking at what's available durable solution, which is mostly either voluntary and dignified return or resettlement to third countries or local integration. But unfortunately, these are very limited in terms of number, given the scale of people who need this kind of support. As a result, nearly 67% of refugees live in this protracted situation. So the other point is, again, just the typical stereotype that you hear about refugee living in camps, which probably used to be the case, probably 20 or 30 years ago. Yes, there are still some living in camps, but I think majority of them live in local communities and in urban settings. And I think we've seen in New York City also with experiencing the same challenge. So I think housing, how do you deal with social service in urban settings, which is different from probably what we are used to responding to refugees in rural and low-income countries. The other thing is a growing gap between, again, the available resource and as well as the need. I think many countries are showing generosity and support for refugee with the resource available, but the growing need is not proportional to the resource that are available. And, many of them, they do experience quite a lot of health challenge. I think, Terry talked about, women and girls, the, sexual reproductive health challenge they face. But I think the other thing is mental health, which is a huge issue that we see. And there is documented evidence that, people who are displaced, especially refugees and asylum seekers, experience high proportion of post-traumatic stress compared to host population. But the other thing is also just a lack of evidence in terms of the health of forcibly displaced population, how to respond to their needs. We do use some of the experience that we get, from low-income countries, but some of them are not necessarily tested or tried in how it is effective for responding to their needs. So there are progress, being made despite the challenge. One is, of course, recognition that migration and displacement as a key development issue with humanitarian elements. So it's not just only, if we think of displaced population living for over 2 decades, you can't just think about this as a humanitarian issue. It's a real development issue. And the cause of displacement is a development challenge, a climate challenge. The solution also has to include economic and development aspects. So, there are many international instruments that are available to promote collaboration and coordination, including, conventions and compacts. But I think, many of them need to be translated in terms of how it does, action looks like implementing those conventions. So there has been quite, a movement in the adoption of the Refugee Compact for refugees, as well as the displaced population, which is a vision of, shared responsibility and enhancing the self-reliance of refugees, displaced population is a key step, forward in terms of, supporting displaced population. And the other piece is, many countries taking, including refugees, displaced population in national health system, rather than running, a parallel health system that doesn't get, meet the need, as well as it creates unnecessary tension between refugee population as well as host communities. So inclusion is a key word I think we like to see happening. I think, both the refugee as well as the displaced people. WHO recently issued as well, the research agenda on the health, migration, and displacement, which is a crucial step, I think, in terms of understanding and bridging the evidence gap for addressing, health need in this context. In terms of, way forward, I think, again, we need to translate this political will that is demonstrated through this compact into, more concrete and actionable steps that can be taken. That's what counts to the people who are displaced. And, this is not just only humanitarian. I think this is an area that requires cross-sectoral collaboration, both from the development sectors, private sector, as well as, government. Of course, we need, finance, not only just aid, but it's also innovative financing mechanism. There are good examples like the World Bank, stepping up in terms of making some concessional loans are available for countries that are not traditionally eligible to this kind of funding. I think that incentivizes countries to create a more equitable and inclusive health system to provide care for displaced population. And of course, we have to think of health system. I think it has been said again and again. Yes, vertical intervention deliver result. But I think the health system that delivers those vertical intervention is what is critical. So, we need to think about, when you think of inclusion in the health system, we also need to think about, groups that may be excluded from accessing service. I would say, displaced, forcefully displaced, as well as refugees are the ones who don't necessarily benefit from national health system. So I think, rethinking about the health system is critical in addressing this gap. Of course, we need to also invest in research and evidence-informed, policy formulation, which is absolutely necessary. And, there's data for understanding our response. And last but not least, there is a refugee forum just in December. I think that's a key moment, really, as global health and humanitarian workers to really advocate for stronger inclusion and commitment of government as well as private sector toward this shared goal of burden sharing, and I would call it as well responsibility sharing for addressing the health need of displaced population. Thank you.
Thank you very much, Mr. And now Ruben, and the challenge is to watch Mariah and her. Yeah, go ahead.
No, thank you, Wafaa, for this opportunity to share about antimicrobial resistance, which is another global health threat. First of all, what do we know? We know that antimicrobial resistance occurs when microorganisms change over time and they no longer respond to medicine, making infections harder to treat, and consequently increasing the risk of disease, illness, and death. But also we know that antimicrobial resistance can emerge naturally, but we know that misuse and overuse of antimicrobial can or accelerate the process of resistance. The World Health Organization identifies antimicrobial resistance as one of the top 10 global health threats. And here I was trying to think what should be the national level action to mitigate antimicrobial resistance, or what each country should consider to invest in to tackle this issue. One is we should develop multi-sectoral national plans to address the issue of antimicrobial resistance, strengthen infection prevention control programs, improve surveillance of antibiotic resistance infections, and develop or put in place regulations and promote appropriate use of antimicrobial, not only in the human sector, but also in animals. Also assist healthcare workers to use the right drugs, in terms of strength, dose, duration, and at the right time, and make information available on the impact of antimicrobial resistance. What is being done, in Eswatini, with support of ICAP? In 2020, ICAP launched an initiative to develop national antimicrobial resistance surveillance capability in Eswatini in partnership with the Ministry for Health, Ministry for Agriculture, and the Ministry for Natural Resources and the Environment, with support from the Framing Fund. The project supports a multi-ministry task force to build a national surveillance system for antimicrobial resistance use and consumption across the two sectors, animal and the human health sectors. And which activities are being focused on? Enhancing laboratory infrastructure. And here I would like to mention that building on other investment that like PEPFAR investment in strengthening a laboratory system, we can also use this foundation to implement antimicrobial resistance surveillance. And in Eswatini, we put in place or we developed, we supported 6 sentinel sites, 4 in the human health sector and 2 in the animal health sector. And then we not only renovated or upgraded the infrastructure, but also supported the equipment. Another area which is very important is strengthening the human resource for antimicrobial resistance surveillance. We trained more than 900 staff in both human and animal health sectors. But another element which is key is building governance and leadership capabilities for the antimicrobial resistance surveillance. And here in Eswatini, we work closely with the multi-sectoral task force called Antimicrobial Resistance Containment Committee, using the One Health approach, which is a collaborative multi-sectoral, as I mentioned, and the transdisciplinary approach with goal to achieve better outcomes. We also supported antimicrobial resistance, antimicrobial use surveillance system strengthening in both sectors, with promoting as well as promoting rational use of antimicrobial medicine, and all this is like to build the foundation for antimicrobial resistance surveillance data use to guide clinical practices in the country. Why is it important, to put in place AMR surveillance system? From our experience, from the phase one, because now the phase one, which was from 2020, to December this year, we learned that, antimicrobial resistance can have impact in improving, practice in the health facilities. For example, in the Eswatini, we realized that AMR surveillance contributed to improving antibiotic prescription practices. Prescribing rate dropped from 50% in the 2020 to 21% in the 2023. Also, we, realized that antimicrobial stewardship committees, which consist of clinicians, pharmacists, lab professionals, implemented intervention to promote rational antibiotic use. And some facilities introduced a non-dispensing of antibiotic policy, whereby the pharmacist will not give patients certain antibiotics without proof of microbiology test order. Another, what are the priority moving forward? I think the first priority is how can we maintain the gain and how can we scale up our services? As I mentioned, like for Eswatini, in the whole country, we have only 6 facilities, providing microbiology services. So we need, to figure out how to maintain gain and also scale up the services to improve access, to those services. But key is supporting data for decision making. How? By ensuring that high quality data are produced on AMR, antimicrobial resistance, antimicrobial use, using patient level prescription data, and also using proxy data such as from wholesale health insurance and also from import data sources. Also, we need to ensure that enhancement of quality of laboratory services to identify antimicrobial resistance, including external quality assurance and the proficiency testing processes. We need also to make sure that the decision makers are supported to understand and use data to manage programs, for programming, and also for policy development. And we need also to support sustainable investment at country level. So this is what I can share briefly, and I would like to acknowledge all the organization you see on the last slides. Thank you so much.
Thank you. Thank you. And thanks to all of the panelists. I think I'm going to go a couple of rounds. Maybe we'll see how we go with the time, but if we make the questions the responses, I'll try to make the questions brief, but the responses brief, and then we will, because we want to take some questions from the audience as well. Terry, I'm going to start with you, and I don't know many lawyers in the world, and I think you're one lawyer that I know, but a lawyer with a heart. We often in public health talk about these structural impediments. There often are punitive laws that stand in the way of being able to deliver services or being able to make people feel safe and appreciated and so on. And I know that you're passionate about this whole area of how can we tackle some of these very big and I know that's a big question. If you can answer briefly, I appreciate it. But how can we think differently about tackling these big structural impediments?
Thank you, Wafaa. That is a big question. We looked at, I like to use this particular research as an example. We looked at Nigeria, where the southern states are actually governed by civil law that is mostly in compliance with international law, and the northern states are governed by religious customary law. Now, just to say, religious customary law can sometimes be amazing, right? But in many instances, it can also be discriminatory. So we took a set of SRH indicators and looked at outcomes in the north and outcomes in the south. And the results were devastating in terms of results in the north being absolutely abysmal. So how do you address that? That's a political will question. It's also about bodily autonomy and people's views on bodily autonomy. I think there could be much more incentivization of compliance with civil law. You've seen many trends in many countries that have criminalized abortion reversing, South Sudan, Benin, because so many young women were dying. So I think we could do much better. Obviously, HIV, using human rights, HIV, the people deserve care. It's been tremendously successful in this context. And I think we have to use those same tools and tactics in the area of law and discrimination, whether it's women and girls or LGBTQ or whatever.
Thank you. I think it's a good example with the human rights lens for HIV and your data. It reminds us again of the importance of data, and even in the context of looking at issues like laws. Jeff, sometimes I wonder, people who are in the health side of the world, we collect health-related data, and people who are in the climate side collect climate-related data. How do you, when you think ahead, and as we want to work both on the effects of climate on health, what are some of the data that we don't collect currently in our health-related work that would be important to be responsive to demonstrate and measure the effects of climate, but also to inform what we can do moving forward?
That's a question we think about a lot, and there's no easy answer because there's so many different areas, health impacts that you'd want to investigate. I think broadly speaking, climate data is much more available. It's generally more freely available. In some areas in Europe and Japan a bit, it's a little privatized, but there's an abundance of available meteorological data out there. The difficulty gets with the health data, and there's so many privacy issues that are associated with it. If we could really get into medical billing records in this country and in many other places in the world, the amount of information we'd have at our disposal would exponentiate. And that's been an issue. That was an issue where we saw with COVID, an explosion in the availability of data that was unprecedented compared to what we'd seen before for infectious diseases. If we can find a way to do that and think about how it's not just it's in our common interest, let's say, it benefits our health, it benefits our security. I think it's really not so much the collection of new data, it's the release of the data that exists that would be really beneficial.
Thank you. And Ashwin, I know you've thought a lot about data and very committed to use of data and so on, and maybe using that example is how do we bring data across, and I'm sure you've thought about across different agencies, across different sectors. to be able to actually do the next step, which is to question it, analyze it, and so on, and use it?
First, I think there's a unique role for the public sector here. When a private institution or any institution says, I can't get medical billing data, it's because it's not available to you, but it is available to us. Mm-hmm. So this isn't a question necessarily of access for the public sector. It's a question of capacity analysis, and yes, sometimes quality of data. So that's one. I think the public sector has to beef up its own internal data capacity, and it cannot be farmed out to either academic or other institutions, number one. And you see this in, you've actually seen very good examples of this in a very strange field, quantitative hedge fund trading around healthcare stocks. They've purchased vast amounts in this country, purchased vast amounts of healthcare data at great cost to them, but at great return, right? And so we have they have built data infrastructure that we need to be learning from, even if we don't have to purchase the data. Number two, we really have to invest in, we have 72 reportable conditions in New York City that health facilities are obliged to send us data on. And in COVID, that was a reportable condition. We had more data than we even knew what to do with. How do you build that out, though, for diabetes and mental health conditions and environmental health surveillance and so on and so forth? This can't all be built on infectious diseases, number one, and it can't all be built on mandates, which means that the public sector has to build up tools and skills like some of the ones I mentioned around visualization and communication and mapping and so forth that actually provides a service to the holders of the data and says, I can provide you actionable insights so you can change your activities in your communities or in the catchment area that you serve. So that's just a couple of things that we think about.
That's very interesting. Thank you. Ms. Finn, you touched on a very important issue several times, which is the importance and the relevance of host communities where displaced peoples or refugees go to or are living in. And and obviously you need the support of the host communities for political reasons, but also for collaborations and goodwill. Are there examples of work that's been done that exemplifies how to prepare host communities, how to enable them to be welcoming, how to get them to be more fully engaged in taking care or supporting migrants and displaced peoples?
Yeah, thanks for that question. Before I answer that, can I just say a word about the data? I think one thing which I would say that disaggregation of data, I think we collect a lot of data. Sometimes, aggregate doesn't tell us, which group are disproportionately affected, whether climate or any sort. So I think that's something that we should do better job. Just to the point you raised about the host communities and preparing. I think there are examples, and when a national law is more inclusive, I think it helps communities also to be welcoming. I think a good example that I know is Uganda, which has very much progressive refugee policy that allow refugees to live in a community, not in a camp. So, which means that they are given land when they arrive, and they build their livelihood as well. And at the same time, the host community also benefit from the service that's made available to the refugees. So that creates a kind of sense of equity, in terms of access to service, and at the same time, that reduced tension that usually happens when you have differentiated types of service for the host versus for the displaced population. So, when you have that kind of policy that allow, that kind of mutual coexistence to thrive, I think it actually helps the local community as well as the refugees. So, that's probably one example that I know, which, exemplify the importance of, welcoming.
Thank you very much. And Ruben, I think not many people really appreciate the data you showed us that AMR is one of the 10 top global health priorities. And I'm wondering, even within Eswatini, give us a little bit of a sense of how did you go about disseminating information about the magnitude of AMR, the importance of tackling AMR, and so on, both at the public, but also the healthcare provider and other sectors?
Thank you, Wafaa, for the question. As I mentioned, AMR surveillance require multi-sectoral effort. Not only the health sector can tackle the issue. There is a need of engagement of other sectors, but also engagement of the high level, to get the support, for the initiative. But also, another key element is community literacy. Using all available platform in the country to disseminate the data, but also use the data to sensitize professionals, caregivers, but also the consumers. Another maybe factor I can consider as enabling factor is always keeping in mind, we organization providing technical assistance, we need to keep in mind that one day we want to be there. We want to be there forever. So we try also to encourage an approach of country-led implementation to enforce ownership, but also accountability. So we try, to discuss using data to discuss, but also use that data to make sure that we agree on the concept of shared accountability in supporting this effort.
Thank you. And Terry, you mentioned, of course, the big issue of gender power asymmetry. I think we could spend many hours talking about that, but we don't have many hours. We have a couple of minutes. But can you think of any positive experiences where programs or interventions have tried to kind of get at that issue in particular?
I mean, I think, there's lots of examples. I mean, I think what we kept hearing throughout the day was the importance of community-led interventions. If you think about shifting gender norms, it would make absolutely no sense that you don't have people in country, on the ground, leading those interventions. So I think where you see true partnerships between all kinds of disciplines with community, in a sense, leading, that's where you see success. And there have been so many. I mean, I think it's really community that have driven some of the major breakthroughs along with science, right? But it's, to me, that's the ingredient to success on gender. And of course, there is a huge, just ongoing power, political will question. But I think, again, more strategic leadership from communities will even help with that.
Great, thank you. Jeff, a question for you is, there are lots of people in this room who are involved as health providers directly or public health feed areas. And can you think of what are thinking about climate change and its impacts and so on, what are the new skills we should be thinking of acquiring so that we can function well and deliver well on all the responsibilities?
It really does come back to education. There's no one skill per se, but you can imagine certainly an emergency physician in a particular setting should really be aware of what is happening to the environment and the climate around and what that means for how you're responding to urgent needs. And a family physician, a general practitioner, has to think about what this means for medication levels, how it means for the ability to even take medicines. The impacts are myriad, and when I say education, it's really about having people who have enough grounding in what the realities of the system, the climate system are, and at how it impacts their sector, be it public health, be it clinical care, be it economics, be it governance. You actually have to have that expertise, and we have to start building that into our population writ large. Because if we're going to tackle this, we really need all hands on deck. We have a planet that we need to steward for as long as there are humans on it, and we haven't been doing a very good job of it. We have been basically using up our resources and leaving the place a mess behind for future generations. So if we're going to actually get on top of that, we need it integrated in everybody's training, and everybody has to bring that perspective to whatever sector they're addressing in their livelihood.
Yeah, I can see an effort to try to include competencies that relate to climate and so on in everybody's education, as I know the school is embarking on such an effort. Ashwin, I'm going to touch on a topic that Mesfin touched on, which is migrants and the migrant crisis and asylum seekers in New York City. And just to share with us some of the challenges, but also some of the innovations that you're bringing to this challenge.
Yeah, a massive challenge in a city as dense as ours, with an affordable housing crisis and a shelter system that was already at or near capacity before we started to take in migrants. From the health perspective, of course, we're worried about infectious disease control, immunizations. We're worried a lot about TB. As you know, TB is not a short-term thing. It plays out over months and years, not weeks and days. Mental health is enormous. We're seeing enormous amounts of trauma and really unmet mental health needs. And of course, just long-term health care. How do we connect people into our primary care systems, our federally qualified health systems? We need institutions like Columbia Medical Center to step up and do more. Everyone needs to care for asylum seekers in this city. And, you know, it is truly a measure of whether we're willing, not just as a city, as a country, to step up for immigrants and to step up for people. This has always been a country that welcomes everyone. And now we're seeing our polarized and divisive discourse really see that 5 or 6 cities in this country are taking on the disproportionate share of hundreds of thousands of people who are arriving, who have arrived and are continue to arrive in our country. And that's not how it should be in this country in 2023, and yet it is. And so we, in terms of innovations, a lot of it is things we've learned during COVID. How do we bring care to where people are? How do we set up mobile care? How do we do things like medical legal partnerships so that we can, in the midst of screening someone for their health conditions, also get them enrolled into parolee health care and start their asylum case at the same time. We have capacity issues across the board, but I'm very grateful for the city's effort. I'm also grateful for all the community organizations that have stepped up to help folks.
Mesfin, a question for you is, we've talked a lot about the importance of community engagement and the importance of getting the voice of the recipients of the services. So my question is about kind of the refugees and displaced people themselves. And, you know, there have been some ideas that have emerged about, for example, many of these refugees, displaced people, may be healthcare workers, they may be nurses or community workers or doctors. Or, how do we utilize them? How do we get them to serve others within their community? And other ideas about how do we get them to the table to design the services they want. So I'm wondering if you can share your thoughts in terms of progress in this space.
Yeah, thanks, Wafaa. I think you touched the core issue. I mean, refugees themselves comes with a skill. I mean, they are doctors, engineers, and all types of, skilled workers. Unfortunately, in many countries, when they arrive, there is no process to recognize their skill and include them in their workforce. Mm-hmm. And that's a major challenge. I think, there are some countries who have done that. I mean, Turkey is a good example. Yeah. When the Syrians arrived, their medical license from Syria was recognized, and they were allowed to practice and help alleviate the healthcare burden in Turkey. So I think that's it benefits the refugees, but at the same time it also reduces the workforce burden on the hosting country. So I think those are the kind of example that will be necessary. I think this requires, of course, quite a lot of engagement. I mean, different countries have different procedures. And I mean, Like in the US, for example, refugee status is determined based on individual status, not as a group. And in some African countries, if you come from a certain group, you are automatically kind of qualified, then the process might be faster. So I think this differentiates understanding the difference and works through the system, I think, to get where refugee skill can be recognized. It also applies when you are looking at resettlement. I mean, we have done some work in Kenya for Somali refugees living in the Dadaab camp who are willing to return, where there was acceptable conditions. So helping them to get skill while they are in the camp, which they have a lot of time, and work with universities across the border to make sure that their certificate is recognized. So this kind of collaboration and facilitation cross-border is what is needed, to utilize, this workforce capability. We are talking about 18 million, workforce shortage by 2030, right? I mean, globally. Yet, we have this workforce who are trained but not legally allowed, to practice. So I think we need to be kind of change the mindset and, be able to find a solution for them to also contribute to the society.
Yeah, thank you. And you're right. I mean, these restrictions are totally counterintuitive, and we have to think about how to tackle them. Going back to our lawyers, maybe can help us here. Turn to Terry again. Ruben, just one last question, and then we'll take a few questions from the audience. I remember when I was in Eswatini once, and we were discussing this amazing program, and you were talking about engaging with the people who deal with cattle and chicken and, and chicken feed. And it's a whole other world that one needs to think about when one thinks of antimicrobial stewardship and AMR. And I'm just curious, what are a couple of lessons you've learned by dealing with people who've never connected at all with this, with us or with the field or with the Ministry of Health and so on?
No, thank you for this question. Yeah, one of the lessons learned, yes, it's important to work with, under the concept of one health approach, but it's not always easy to bring together different sectors for maybe different reasons. One of the reasons is, for the health sector, it was very easy because we could capitalize on exposure, technical exposure with PEFA, resources from, Global Fund and others. So different sectors were at a different level of, resources and, previous investment. And this one. Second, the issue was mainly in, having an integrated system for data management, because systems were still operating in silos, and yet we are talking about one health approach. So the lesson learned, yes, building a one approach system, it's paramount, but it's time consuming. But we need to keep engaging. If I can give you the example of the question you asked me earlier about how we disseminate data, I can give two quick, concrete example of the platform we use. One is this month we have what is called World Antibiotic Awareness Week in November. So try, to engage all sectors using available data to disseminate, but to also use that data to sensitize a different level of leadership so that they can invest more in the effort. And the second one is each country is required to report to WHO GRAS because there are a number of pathogens, tracing pathogens that each country should report as tracing pathogen. It took time to kick off that reporting because sectors are not yet ready to release the data for different reasons. Yeah. So there are a lot of lessons, learned, but mainly what we learned is like engagement, stakeholders' engagement is the key, and using data evidence is a strong tool, to persuade the leadership.
Great, thank you. It sounds like data is a tool to get the engagement as well. It's almost like a cycle, virtual cycle. We'll take a couple of questions from the audience. We have the microphones here and here. Yeah, I think people are hungry. So we're going to take a quick question.
My question is for Commissioner Vassan. You mentioned about, right here, you mentioned that our radar may have been a bit scrambled at the onset of MPOX as a result of the COVID-19 experience. I imagine that the converse can also be true if we go a long period of time without having a major public health emergency. I would love to know one thing that the Department of Health is doing right now, particularly a public-facing or community-facing thing that you are doing now to ensure that the next time that we do have a real public health emergency, that we are able to sort of mobilize that apparatus more quickly.
It's a great question. One great example is a program we built during COVID called Public Health Corps. It involved 100 small community-based organizations in the 55 zip codes in New York City that were hardest hit by COVID. These are not organizations that ordinarily get dollars from the city. We have large nonprofits in this city that get a lot of money from the city of New York, but small community organizations with credible messengers, people who are there all the time, people who are trusted voices, who are engaged, whether they're faith-based organizations or community advocacy organizations or legal organizations, getting them dollars and making them permanent and actually equipping them with community health workers and getting out of the way. So the city doesn't really need to be involved other than getting them the resources and then maybe following up and providing technical assistance. So, but that's a perfect example of a fiscal cliff we're facing. We built that with federal dollars. How do we permanentize that? So that work is ongoing, but we have to address the long-term fiscal outlook to make sure that that's a permanent part of our readiness infrastructure.
Great. I think that was a very good point to end on. And I want to thank our panelists. I want to thank our keynote speaker. I want to thank all of you for being here today at the symposium. It's a great pleasure. I think we've learned an awful lot from all the insights by all of you. And now invite you to please go upstairs to the fourth floor where there'll be lunch, and you'll also have the opportunity to take a look at some posters that were developed by the various countries, teams where ICAP works, so you can get a glimpse on at least a little bit on what they're doing day in, day out. Thank you all for being here.
Oh, okay.